everyone. I'm Mike Freelander, the Chair of the Standing Committee on Health, Aged Care and Sport. I must say it is a bit intimidating looking around the room to see the degree of expertise we have, and on behalf of the committee we'd all like to thank you so much for coming this afternoon and giving us the benefit of your expertise. I'm required to make some comments before we start the committee hearing. I'd like to declare open this public hearing being held at Parliament House in Canberra of the House Standing Committee on Health, Aged Care and Sport for the inquiry into long COVID and repeated COVID infections. In accordance with the committee's resolution of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. For any media in the room, I note that recording must not occur from behind the committee or between the committee and the witnesses. And computer screens, documents and mobile phones belonging to members must not be filmed, photographed or recorded. Witnesses are reminded that they can object to being recorded at any time. The committee thanks the media in advance for maintaining a COVID-safe approach while in the hearing room. I'd like to make a few brief opening remarks ahead of this roundtable event. The committee commenced this inquiry in September 2022 because we recognise that long COVID and repeated COVID infections are emerging as two new health challenges for Australia and indeed the world. As part of this inquiry, we're seeking to understand the health, social, educational and economic impacts of long COVID on individuals, families and the broader community. We are also looking to the future by investigating research and best practice for the diagnosis, management and treatment of long COVID. Earlier today, the committee heard from multiple individuals with personal lived experience of long COVID and other post-viral illnesses. This afternoon we'll take a broader lens and hear from experts brought together by the Australian Academy of Science and Australian Academy of Health and Medical Sciences. The committee welcomes you and we look forward to hearing your perspectives and ideas. I'd like to thank the academies for convening this roundtable, and now I'd like to hand over to Professor Chennupati Jagadish, the President of the Australian Academy of Science, and Professor Steve Wessling, the President of the Australian Academy of Health and Medical Sciences. So I'd like to hand over to the two heads of the academies. Thank you.
Thank you, Dr. Janet. Welcome everyone to this roundtable on long COVID, convened by the Australian Academy of Science and the Australian Academy of Health and Medical Sciences to provide evidence for the House Standing Committee inquiry into long COVID and repeated COVID infections. The academies thank Committee Chair Dr. Mike Freelander and the committee members for accepting our offer to convene Australia's multidisciplinary experts to provide perspectives to inform emerging policy issues relating to long COVID. Thank you to all the roundtable participants who have joined us here in person at the Australian Parliament House today, and the participants online who are overseas or otherwise couldn't join us in person. Thank you for generously contributing your expertise and experience to this important discussion. I would like to open this roundtable by acknowledging the Ngunnawal people, the traditional owners of the lands on which we meet today. I also acknowledge and pay respect to the traditional owners and elders of all the lands on which the Academy of Science and the Academy of Health and Medical Sciences operate and its fellows live and work. The Australian Academy of Science and the Australian Academy of Health and Medical Sciences are learned academies that provide independent and evidence-based scientific and health advice to government. We have amongst our fellows some of Australia's leading experts across a range of scientific and health matters, including researchers, health professionals, and individuals working in industry. The Academy of Science and the Academy of Health and Medical Sciences provided a joint submission into the inquiry and highlighting that a national coordinated effort and a health system in which research and innovation are embedded as core functions and will be best equipped to understand and address ongoing challenges arising from the COVID pandemic. We also offered to bring together some of Australia's leading experts in long COVID to help inform the committee's deliberations. The Academy's independence and convening power make us an ideal host for today's roundtable, and we are pleased to be able to provide parliamentary committee members with the direct access to those at the forefront of long COVID research and treatment. In our democracy, it is critical that our leaders have the evidence and independent, trusted advice to make decisions on issues that affect society and our future. This roundtable is an example of the unique role of the learned academies and their remit to provide independent scientific advice to government. We hope that this becomes a blueprint for future inquiries. Now, I'll hand over to my distinguished colleague and President of the Australian Academy of Health and Medical Sciences, Professor Steve Wessling. Steve, please.
Thank you very much. Thanks, Jagadish. And I'd like to acknowledge your comments and absolutely agree with your comments. Before I start, I'd also like to acknowledge the traditional custodians of the land that we're meeting on, and elders past and present, and any Aboriginal or Torres Strait Islanders in the room today. I think it's very clear that long COVID is a challenge for Australia. It's a challenge for our community, it's a challenge for our patients, and it's a challenge for clinicians and the health system. And I thank the committee for doing the work that they're doing on this, because it is really very important. And I also thank the committee for inviting the academies to join you today, and very much thank the people around the table who really are Australia's superstars in this area. You know, we have amazing virologists, public health physicians, clinicians, and so on around the table who are all going to today, I think, contribute enormously to the committee's understanding of the issue, and hopefully together come up with some really great recommendations. Because I honestly believe that if we look internationally, this is a challenge the world is facing, and no one has dealt with it particularly well. And actually Australia can, through the expertise, the like that's around this table, with appropriate coordination, develop models of care, can develop models of research and models of data acquisition that could lead us to solutions for this really difficult problem, and actually be leading on an international scale. Even if we're not necessarily right at the front of that, by being around the front of the pack in that area means that our patients will get better care, because we will be understanding this condition better than most around the world, and in the end that's the most important. Finally, I'd like to thank Tanya, because Tanya's done an enormous amount of work in aggregating this group, in talking to everyone, bringing them all here, and finalising the agenda for today, and really has led us all down the path to this group here today. And I'm really hopeful at the end of this session that we'll have some really important outcomes and some suggestions to the committee, and then ultimately to the health system, that could make a big difference. So thank you very much. Tanya.
Thank you very much, Steve, and good afternoon, everybody. I'd like to add my welcome to those that have been forwarded to you already, and to acknowledge the traditional custodians of the many lands in Australia on which we're meeting today, either from our online colleagues as well as in this room, and particularly to acknowledge the Ngunnawal and Ngambri peoples on whose lands this roundtable is being held, paying respect to elders past, present, and those who are in the room with us today. I'm honoured and thank the two presidents for asking me to chair this meeting with our leading Australian experts, not all of them of course are in the room, to consider key research questions and issues to be resolved so that we can reduce the impact of long COVID in our country. It's clear from discussions that there are major ramifications, of course, for those who actually suffer from this problem, which in turn will impact on society, access to and provision of healthcare and support, and for health systems generally. So we hope that this discussion will better inform the House Committee as they consider the various submissions to their inquiry into long COVID and repeated COVID infections. I would like to thank all of the roundtable participants for their work thus far and for their attendance today, and to thank you too to the Parliamentary Committee chaired by Dr. Freelander for participating and joining with us. I acknowledge there are people online, and we will refer to those names subsequently for the purpose of Hansard. But in summary, with the background that you've already been provided by the former two speakers, we've agreed in collaboration with the Parliamentary Committee Secretariat on 4 key issues to address today. The first of those is to agree on the principles on which to base a workable standard definition or framework for the definition of long COVID, which we agree is long overdue. To identify the most significant knowledge gaps requiring further research around long COVID, to prioritise actions that will address those knowledge gaps, and to provide recommendations on how government, the research and health sectors can work together to deliver those actions. Now, that's quite a big agenda, and in order to be able to focus on those aims, it was necessary to identify some areas which, though important, are out of scope for this meeting. And these include things such as the impacts on broader healthcare delivery, the preventing the spread of COVID, that is to say, it's logical that the best way to prevent long COVID is not to get it at all. That's not on our agenda for today. And we will not be able to address specific health advice related to any individual case. I'd like to just talk a little bit about the structure of the day so that we can achieve some valuable outcomes for the committee to take forward. It's outlined on the agenda slide, which I think you are about to have before you. Yes, you have before you. And each discussion session will be followed by 10 minutes for the Parliamentary Committee to ask questions and to have some exchange with any members of the roundtable who are here today. We hope to have 20 minutes available for afternoon tea, but you would understand some flexibility might be needed around some of the timing of this session. And in the concluding session, we will aim to summarise key discussion points and highlight key priorities to be taken forward. Now, again as background, to inform discussion in each session, many of the participants have actually already provided input, and I will be presenting some of that on slides so that we have a framework around which to run this discussion. It should have been forward with the meeting packs, and everyone should have had that available. With the rules of engagement,
please stand by for instructions from your nearest security officer. I repeat, please stand by for instructions from your nearest security officer.
may we proceed? Thank you. With the rules of engagement, I will endeavour to make sure that as many participants as possible can speak and that we will have a meaningful and robust discussion, but we do have 28 participants around the table and the sessions are relatively short. So to facilitate that, we have asked people to prioritise questions that they might like to speak to, and I will prioritise them for initial discussion. Secondly, if
Sorry,
people...
Professor Cirillo, if you could just pause for a second. It may be as simple as someone just having a smoke in the toilet, but...
You're challenging our time.
Okay, proceed.
Thank you. If people do not get a chance to speak, you will be able to provide written commentary after the roundtable.
Attention, please. Please stand by for instructions from your nearest security officer.
I think it's okay to proceed.
Please stand by for instructions from your nearest security officer.
And any commentary that is received after the meeting will be forwarded to the Parliamentary Committee. To engage my attention, please raise your hands, whether in the room or online, as we don't have an online hand-raising function. And online participants, please remain on mute when not speaking. Before we begin the discussion, we need to go around the room to state your name for the purposes of Hansard. Tanya Searle.
Andrew Lloyd.
Dennis Lau. Ian Irving. Brendan Crabb. Martin Henshaw.
Julie Lees.
Jeremy Nicholson.
Kirsty Short.
Jade Crock.
Anne Holland.
Phil Britton.
Margaret Heller.
Andrew Bailey.
Jodie McVernon.
For the people online, could you turn on your videos, please? And I can't actually see your names, but Sharon, would you like to start and then people proceed from there?
Sharon Miller.
Someone speak up.
Gail Matthews. Penelope McMillan.
Please, attention please.
Christina Stenser.
Stand by for instructions.
Michelle O'Brien and Penelope will be speaking for me today, thanks.
Repeat. Stand by.
Does that complete the list?
Connie Ryan. Christopher Miller.
Sorry, repeat the last one.
Adrian Miller.
Christy Crooks.
And we understand one of our number is still to come, is waiting to get into the building. And that is Maria Crotty. So we should move on, I think, to the discussion, to session 1. And here we are really aiming to develop principles for a workable standard definitional framework. If we could move to the next slide, please, Lauren. You've heard some background, and we know that there are multiple definitions of long COVID in use around the world. The World Health Organization definition is probably the most commonly used, but we all agree
Sorry
that...
to interrupt, Professor Searle. We need to actually evacuate. There is a problem in the marble foyer, so if we can just move outside.
So we'll stop discussion for evacuation. Here's some discussion around so that it can be taken forward without a standard definition that really meets the needs of different end users in the final analysis is critical for the things that have to flow from that and, of course, to improve outcomes at the end of the day. So the way that we had planned to do that was really look at determining the key principles from which to develop a definition of long COVID, that being done post-roundtable, and to suggest some actions that the Parliamentary Committee can take forward in relation to that. And out of scope is consideration of the earlier post-COVID syndrome. So if you could just go to the next slide, Lauren. We're all aware that the WHO definition is the one that's been used most often, but there seems to be general agreement that it's too broad and it's not really fit for purpose in the more specific sense. And to our mind, the primary purpose of a case definition is to serve research, surveillance, that is, understand the extent of the problem, clinical care, access to social or disability support options, public health, policy development, and health system planning, which has implications for the workforce that is impacted by long COVID and for future needs. And to cut to the chase, perhaps, there is a bit of a dichotomy between a clinical and a research definition, because the clinical definition does not have to be quite as stringent. For research, we've clearly got to look at people who've actually had confirmed COVID if we're going to try and study long COVID. Not everybody who has a clinical syndrome will have had that confirmed diagnosis, just as an example. The WHO definition does have a number of drawbacks. It was developed as a clinical definition. It does have ambiguities, and as Andrew will perhaps comment later, it's not really been operationalised. We have a definition, but how to actually utilise it in different settings has not been standardised, and it has not been validated. It has been adapted for a number of research studies, but they've often used slightly different criteria, which of course compromises comparisons and how we can interpret that data and use it clinically or in public health. Just some examples of the ambiguities are to do with the definition being described as probable or confirmed, to do with the fact that it's usually 3 months from the onset of acute COVID, or is it ongoing from the differential diagnosis? But the usually 3 months construct also has symptoms that last for at least 2 months. Now, what does usually 3 months mean? It's difficult. New onset following recovery or ongoing, as I mentioned briefly, cannot be explained by an alternative diagnosis. People need guidelines as to what alternative diagnosis you're trying to exclude before you can have long COVID as the primary diagnosis. And then what is meant by overall having an impact on everyday functioning? We need some more clear assessment that's quantitative for the impacted community. It also needs updating to account for new knowledge and the stage of the pandemic that we're at. So looking at what we would call comorbidities or other conditions, how do we factor those in? Because they might affect risk, or they do affect risk, we know that. Looking at syndromes that arise post-acute COVID and seem to be in relation to it, like cardiovascular symptoms or diabetes. Looking at new diagnostics that might be specific for COVID, or at least consolidate the diagnosis clinically, quantify functional impairment, etc. So those are, just some of the difficulties with the definition there. Now, I did have a slide I was going to talk to about some of the key considerations, and they include whether children and young people need something specifically for them. Are there phenotypes or the subsets in the long COVID truly different, or are they really influenced by developmental or family or social or other contexts? And what's the impact of long COVID on their developmental milestones? So there are a number of areas, I think, that we do need to operationalise, to define, and the intent is not to do it within this group today, but rather to agree on a set of principles. In summary, long COVID is heterogeneous with different underlying causes, so we have different phenotypes and subsets that require different investigation, management, and ultimately support. And there are some key principles, I think, which would not be particularly controversial, and therefore I will not go through them in the interest of time. These slides will be made available to everybody afterwards so that you can see them, but perhaps mentioning just 2 out of 5. One is that they need to be workable, they need to be easily understood and meaningful to practitioners, consumers with lived experience, the broader population, including First Nations, people with culturally and linguistic diversity, and other vulnerable groups, and to policymakers. They need to be co-developed or modified in collaboration with lived experience, clinical and diagnostic discipline experts, researchers, public health and health planners, and international colleagues. So I hope you will agree that those are not particularly controversial, and I'd like to throw to my colleague here, Andrew Lloyd, to just look at the principles or outline of where we are with COVID at the moment, and long COVID in particular.
Thanks, Dania. And again, without hoping not to be controversial, I'd like to outline what I would call a pragmatic framework for how, in clinical practice and in research practice, we could start to operationalise what is currently the heterogeneous beast of long COVID. So to do that, I might just take you through something of a compartmentalised journey, which starts with an acute COVID infection. Down on the right, you can see what I've portrayed there is that in individuals who have prolonged symptoms after acute COVID, so 8, 12 weeks or longer after the acute illness, it's just intuitively, it's plausible that that might have a traditional medical explanation. And that might be that there was pre-existing heart disease that got worse in the context of COVID. It might even be a psychological disorder arising de novo or as an exacerbation of a pre-existing morbidity because of the pandemic context and the challenges of managing an uncertain illness. So there are a number of boxes I've got there which suggest that there are medically explainable reasons why some people have persistent symptoms. and in a clinical practice sense, recognising those and managing those, and especially if they are the explanation, that management should lead to hopefully resolution or improvement. So I have one whole arm in my pragmatic model which says look for medically explained conditions. Now, we can come back and talk about how we operationalise that. How do we guide which investigations, which clinical assessments need to underpin that? And the same's more or less true on the flip side. Next one for me, Lauren, good on you. On the flip side, in the blue, I've got what you might call the counterpoint. This is where there are medically unexplained symptoms. So, for instance, the dyspnea has persisted, but the lung function is pristine, and the cardiac function and cardiac structure are untouched. So, dyspnea, therefore, is what we might call medically unexplained. And the same's true for many of the other symptoms like brain fog, etc. So in that realm, it's absolutely clear already that there are syndromes that we would otherwise make a syndromal diagnosis for, like a post-infective fatigue syndrome, or if pain's predominant, it might be a fibromyalgia syndrome where pain on palpation is a feature. And it might even be a postural orthostatic tachycardia syndrome, a disturbance of autonomic function leading to palpitations in addition to fatigue and brain fog and other symptoms. So we need to recognise those syndromes as an outcome, and there are already reasonable working definitions, case definitions, for those syndromal outcomes. But they also need some guidance of what's going to be the investigation list or the clinical assessment protocol to get to those syndromal diagnoses. So I'd like to propose to the group, and I'm happy to hear comment and input, that we could brand long COVID under that broad brush, but pigeonhole patients and research populations into one or more of these boxes. I flagged at the bottom of the slide there that although I'd love to say it's all pigeonholable, actually I don't think it's going to be. My sense is there will be comorbidities that were pre-existing or maybe are partially explanatory but not completely. So there's going to be overlaps, and there might be a fatigue syndrome as well as some cardiac failure, so there's some complexities. But my sense is the majority of this approach, it'll work for the majority of patients. The other thing I wouldn't mind to flag, which we could move on to as a separate discussion point, if Tanya thinks it's appropriate, is there are a lot of efforts going internationally in this space to make a case definition. So although I'd love to think we could do it bigger and better in Australia, we might need to get with the strength and align with those international case definition efforts.
So thank you, Andrew. I think we'd like to invite comments at this stage, not so much from the committee, you have an opportunity shortly, but from around the table. Would any of the experts here today like to comment on what you've heard so far? Dennis.
Yes, we've done autonomic testing in a large group of long COVID individuals and has found 70 to 80% with postural orthostatic tachycardia syndrome. And I think the under recognition of this and not testing for it is a problem in many long COVID clinics. And I'd like to add that the ultimate goal is really for us to track the prevalence of this, is to have an ICD code for this condition to be recognized so that it's coded. Patients are coming to ED and sent home without a diagnosis sometimes, just dizziness on it or chest pain. But if you have a definition, we must follow through with an ICD code. The US has added the POTS in the ICD-10, which is coming and already been out there, but that has not been adopted in Australia. So I think we should push for that.
Thanks, Dennis. Jeremy.
Yeah, in addition to the obviously requirement for a robust medical and operationalisable definition. We also have to bear in mind that we are trying to develop therapies for this. So the definition has to in some way incorporate metrics for recovery caused by therapy. Otherwise, how do you know your therapy is working? So it has to have a molecular element as well as a clinical element, in my view.
Sure. Did you want to comment further on some of the metabolic complications, because we aren't really accounting for them in the actual construct of supportive diagnosis?
Well, so we've done a great deal of work on metabolic phenotyping of COVID patients and long COVID patients using samples from all around the world. We've done tens of thousands of patients from around the world now. And one thing that's quite important to note is that actually there's a great deal of similarity in the metabolic phenotype subsets between different ethnic groups and different countries from around the world. And although those people are metabolically different, COVID pushes them all in the same direction. And we find that, for instance, Spanish populations and Australian populations are completely cross-modelable. Okay, so that's quite important, because if it was different in every country, we would really have a very, very big problem. So one of the things that we've been working on is looking at the journey from normality to abnormality. We call that phenoconversion. And then when you come back to be more normal, you recover. We call that phenoreversion, reversion to the shall we say, the normal population state where you should be for your age and sex, etc. So we've been trying to map that out. And what we've found is that people vary enormously, not only, of course, in the severity, but also in the timescale over which the symptoms and the metabolic abnormalities occur. It's multi-organ. Almost every organ in the body is involved. Almost every organ in the body has a metabolic signature. So you can use a metabolic signature to actually classify people according to which major organ systems are involved. And those are objective and numerical measures of change. And so we can actually look at an individual and see how normal they become with respect to liver function, pancreatic function, cardiovascular risks, etc. So the metabolic angle is very important, but there's lots of metabolic disease and conditions that can be quite severe without having any symptoms. So we know that new onset diabetes is caused by COVID, but that doesn't have any symptoms until you're really quite severe. Same applies to lots of liver disease, and the same applies actually to cardiovascular disease as well. So there's we call that occult long COVID, right? When they're not necessarily symptomatic, but they have nonetheless medical abnormalities. And of course, as just been said, you can have predisposing conditions that make COVID worse, but COVID makes those conditions worse as well. It's both bidirectional.
Thank you. Yes.
Coming from a patient perspective, I think one of the problems is the sort of atomisation of patients into medical subspecialties. And one of the principles we've always used in our clinic is to treat the person as they come. Inevitably, they end off getting referred to cardiologists, gastroenterologists, and language drives systems and language creates things. And Heidegger says, your name brings something into existence. And I think although I think it's an elegant model, the alternative model is a sort of dimensional model which allows a sort of an axis of symptoms, an axis of function, an axis of severity, an axis of trajectory, which in a way has a descriptors but doesn't put people into subspecialties and mean that they're going to be, having taxi ridings around spend their time chasing subspecialties. And I think we need to think about that fundamental problem with COVID, about, categorisation versus dimensionality at this very point.
I'll just ask Jen Cock to comment from the specific diagnosis point of view, then perhaps come back to you, Andrew.
Yeah, thanks very much, Tanya. First of all, I think it's not that always easy to diagnose acute COVID, where we are at the moment, because a lot of tests that are being done at the moment are rapid antigen tests, not like in the first few years where we were doing RT-PCR to diagnose COVID. So we were capturing the patients or the people that had COVID a lot better. Serology, unfortunately, which was useful in the first few years as well, is currently not so useful to tell whether someone's had COVID or not. And of course, this is one category of diagnosing it in adults, but then will be different as well in children, who obviously different characteristics, and the tests perform a bit differently. in addition to that, the sort of biomarkers that one could potentially use, it would be very elegant if we did have a biomarker or a set of biomarkers to test people for long COVID. I don't think we're quite there yet. And there are different syndromes, if you like Professor Lloyd has categorised, that if you have pulmonary predominant long COVID versus neuro predominant long COVID, those sets of biomarkers potentially could be very different. So I think it's certainly very challenging to, in this current context, diagnose long COVID and also acute COVID as well. Yeah. Thanks.
Thanks, Jen. Yes. Kirsty.
Can I just echo the comments about a need for some sort of biological marker or something that's consistent across studies? Because from a research perspective, it's a very, very difficult area to research and come up with therapeutic ideas because there's just no comparisons between studies. So I'm really optimistic that we can find biomarkers, and I really think that fundamentally it's going to be the immune response that gives us that insight, because we are seeing lots of immune disturbances in long COVID patients. But I think some sort of biological definition is also really important.
Andrew, would you like to reflect on those comments?
Yeah, a couple of things I'd say, and mostly this reflects my experience of a couple of decades of research in relation to post-infective fatigue syndromes and the more difficult chronic fatigue syndrome. Ultimately, perhaps from a health service perspective and to some extent from a research perspective, the dimensionality notion is problematic, because what matters for health service is to have a threshold of need for health service intervention. So in the fatigue syndrome world, we would say the fatigue needs to be associated with disability, because if it doesn't have disability, it's a problem, but it's more of somewhat less significance and just requiring symptom control. But if it's causing disability, then it's a problem. And the same would be true for pain or any of the other symptoms, or the symptom as a complex. I do recognise that the instruments that we're talking about proposing here to operationalise, some of them are dimensional, some of them have caseness. You know, when does this reach a threshold where it's problematic and are validated as such? Some of them don't have that, and they're really just a linear scale of how bad is part A or B or C. And so each of those have their merits, because at the clinical practice end, we would typically think about, maybe not with a formal scale, but we would dimensionalise, if that's a valid word, the severity on a series of axes and say, oh, well, look, those things should get prioritised and these that are lower on the severity scale should be less. So I think both come together in clinical practice, but for research, we need, like Kirsty was saying, we need pretty tightly defined syndromes, and my sense is that's going to be disability is the threshold. And there are precedents set for how that can be operationalised in the fatigue syndrome and fibromyalgia world.
So very quick comment from Julie. Then I'd like to throw to someone online. Could I just, before you start, Julie, people online are not showing your faces. If you wish to speak, please show your face. Julie.
So in thinking about access to care, a definition would want to ensure there's equity of access to that care. So if you have a expensive test, for example, that confirms your long COVID, then that will reduce your access to care if you don't have access to those resources or those healthcare settings. So I think in terms of principles, equity is something that's important to think about.
Martin, do you have an extremely quick comment?
Yeah, very quickly. So just to echo, operationally, research definitions are very important, but we're going to need policy operational definitions very soon to be able to really drive people's eligibility for a whole set of health and social services. And so we need to move quickly on that and not be scared to adjust them later if the research then requires adjustment. For those operational definitions, we cannot insist that that's tied to laboratory confirmation of COVID infection, because most people who've had COVID in this country at best have a rapid test. Maybe down the track we have to change testing policies again to, if we want a tighter definition for eligibility. But right now, we need a pretty wide definition to drive people, those people who with severe illness who need access to services.
So I would now like to invite Michelle O'Brien, who is online, who is our Consumer Forum representative. Michelle, would you like to make a brief comment, please?
I did say Penelope will speak on my behalf. Thank you.
I'm sorry?
Michelle's nominated me to speak on her behalf this afternoon.
Oh, pardon me.
This morning,
Okay. Right.
she's suffering from the effort this morning.
Right.
First, to thank you to the academies for recognising that consumers are experts in lived experience and inviting the Consumer Health Forum to nominate someone to represent people with lived experience at this event. And it's my great privilege to be that nominee this afternoon. I have comments on three aspects of the model. One is that we haven't really talked about length of time, and that's been a very common definition around the world. And I'll put it to forward that we can accommodate multiple lengths of time in a single standard definition. People with lived experience desperately want urgent intervention, and they don't want to wait for a length of time that might suit researchers or might suit data collectors. They want a brief length of time. Secondly, are all post-acute sequelae long COVID? The model that we've seen, there's a fairly strong global body of opinion that what has been described as medically explained are post-acute sequelae, but that long COVID should be reserved for the chronic illnesses that follow COVID infection. And then there's well, as Professor Lloyd would know, I would argue against the notion that they're medically unexplained, but that's an argument we've had of long standing, and Professor Lau might like to discuss that too in terms of POTS and dysautonomia. But there's a growing body of evidence that amongst people with chronic illness that's been triggered by COVID, that there are three really clear groups. First, there are people who have new onset autoimmune conditions. So that's diabetes, rheumatoid arthritis, lupus and more. Then you have, as Professor Lau already said, 70% of people with objectively identifiable POTS. That's just one manifestation of autoimmune dysfunction, but clearly autoimmune dysfunction is a massive portion of people with long COVID and they are identifiable. And then again, from metadata, we know that 50% of people with long COVID have ME/CFS. That was predictable from prior epidemics. And the numbers do add up because people with ME/CFS also have autonomic dysfunction. Does it matter if we know whether they have ME/CFS? Yes, it does, because people with ME/CFS have exertion intolerance. That has massive clinical research and data implications because of safety. If you're on a human research ethics committee, you need to know, have these researchers taken account of the fact that some of these people will have exertion intolerance? Have they identified which people they are? So, thank you.
Thank you very much for those comments. They're very helpful. I do apologise to two of you online who clearly would like to say something, but I do think we need to move to the next stage of the discussion to which you may well wish to comment, and then we will ask the Dr. Friedlander's committee for questions. So towards a definition, what are the next steps? I think we've articulated as a group having feedback to ensure international alignment, which has been alluded to. What about the here and now in Australia? What are the next steps to actually have a current definition that will suit us, but of course not only us, but be internationally consistent? And then the actions that the Parliamentary Committee can take forward to try and facilitate achieving those aims. So I did want Andrew to just briefly comment on our alignment internationally and the prospect of what we should do about it.
Yes, I feel strongly that it's not a smart idea for us to reinvent the wheel here in Australia. So to give some sense of what's happening internationally, I'm part of an endeavour that goes by the acronym of COFFEE. That's the Collaborative on Fatigue Following Infection, which is an international consortium of prospective cohorts, including after COVID, but from other infectious diseases like glandular fever also. And that endeavour is in the process of reaching out and has gained some traction with some of the key international organisations that might have an interest in improving the case definition, including the WHO that came up with the initial definition, but also the Centres for Disease Control, the NIH in the US, the European CDC and the MRC in the UK. It hasn't completely formulated yet, but my sense is there will be a working group of those organisations being formed soon, and we can look to Australia for participation in that process. And this is intended to make definition for post-infection fatigue syndromes, including that subset of long COVID that falls under that banner. Like I was saying, I think we need to align. The agenda of that group is also to operationalise, so to recommend which questionnaires, which investigations, which assessments are adequate to make a definition in a clinical or research setting, and then to validate, to use existing cohort data to say if you put this element into the definition, how it would change the impact of how we would define the illness. So
Thanks.
it's a work in progress.
Thanks, Andrew. So that's not a short-term solution, and so what we need to obtain views about is what to do in the here and now for Australia, and then the more consolidated and internationally aligned things. So would members of the committee, the round table, like to suggest how we might best help the parliamentary committee move forward with the definition for the here and now, and then its further updating and development? Margaret.
So I think for the here and now, it gets a little bit back to the initial question, or one of the questions that was posed is, what is the purpose for having a diagnosis here and now? Mm-hmm. And is it for the clinical purposes that Martin articulated as opposed to research? Is it for the purpose of, as well though, can we just have enough in there so that it helps us actually properly measure, so that we can go, well, it might take us a while to have the global definition, but we can bounce from that. So it's for the clinical, like it's for the purposes of helping patients or people impacted by long COVID now. Like that should be our first purpose, I would have thought. And then to say, well, we recognise we would also like to have a few extra things if we can, without it being onerous, and whether it's, and to Julie's point, if it's a biomarker, is this accessible to everybody? That kind of thing, so that we can be sort of setting our sights on the longer term measure, because I think it's critically important we begin to measure really accurately in a way that has the research notion, because that helps us properly then predict what's likely to happen in the future. So that's how my here and now.
So what are we recommending the committee to do?
I'd be recommending that we go really simple, like what is required.
No, how are they going to do that?
Oh, assessing what is required to have a clinical definition so that people can access the services they require quickly.
Who are they going to say should do it, and how are they going to decide?
Okay. Well, then you would get, for the clinical one, you would get clinicians who are actually doing long COVID clinics at the moment and patient groups together to actually help with that definition, and then have a small group of researchers or measurers, surveillance people adding to that.
Julie, do you want to say something? And then Louis. No, Louis, did you want to comment?
I think in our experience, GPs are pretty good at diagnosing it. You know, by the time the patient comes to our clinic, they've got a pretty positive diagnosis, and the things that it could have been ruled out.
Okay, I mean, that's a really important comment, because I think feedback from some of the people with lived experience is that they're concerned that some GPs are really not up to speed with it. Steve, you were talking about some options before. Do you want to just articulate where the committee should be assisted in deciding what to do and how?
Yeah, again, it goes a little bit to your point. I think that if we could very quickly develop a model, a relatively simple model with the right tests that to exclude the diagnosis of other diagnostic opportunities, but also then lead to the diagnosis and share that widely with primary care, I think that would be probably the most helpful aspect, because I suspect the specialty clinics, or a lot of those represented around the room, are also pretty good at it, but there's a lot of people out there who are either worried, afraid of making the diagnosis, or for a variety of reasons, and therefore not helping their patients or sending their patients elsewhere. And so I think a very simple model of diagnosis, and also tests that would exclude other things, because we don't want people missing things like multiple sclerosis or other things. Yeah.
Okay, are there any other very brief comments before we ask the Parliamentary Committee to discuss what they've heard with us and how we can help them further? Yes, Andrew, very brief.
Just to clarify, are we saying today use WHO, in a couple of days use the thing that we're going to develop, and then in a couple of weeks coffee will come forward? That's
you might
not
stretch those timelines.
No, but it seems to me like we're probably saying today use WHO.
Yeah.
We don't have time for too many. It's 5 words, Phil, and 5 Jodie.
Just with respect to children and young people, I think definitions for adults will function adequately for children from about 10, and I really would advocate the UK consensus definition for long COVID in children. It's probably the most robustly developed definition of all. But for under 10s, I think this is a wide open space, and I would caution against using adult definitions for younger children. And I suspect we don't actually have sufficient data published to really know what this might look like in young children. But paediatricians are well placed to support that, but I don't think we can go much further than saying we don't really know for under 10s today.
Last comment, and I've been asked for you to say your name before speaking.
It's Jodie McFernan. I guess I'm just linking some of what's been said to what Martin was referring to. With any of the definitions, I guess just ensuring that they are reportable, recordable, identifiable in data to inform burden assessment for program resourcing and also the impact of interventions. So just thinking about, and people like Lena, how are we going to find these? And can that all be done within the existing systems, or do we need augmented studies to understand those burdens?
And how do we help you, or you identify who can actually do these things for you? Would you like now to reflect back to us, Mike, or people on your committee?
Look, that would be great. I just sort of very quickly point out that our committee is tasked with doing a report for the Health Minister so he can act on it, and we hope to get that report through as soon as possible. So if there are any budgetary measures that have to occur, we can then get funding. And so it is important for us to get some action quickly rather than wait a long period of time. I just point that out. But anyway, we'll throw to Dr. Gordon-Reid as first questions.
Excellent. Thank you, Chair. It's a question to the panel. In the algorithm that you had on the screen earlier, there was the symptoms that are medically explained, symptoms that are not medically explained, and the word prolonged symptoms. I suppose my question is, with the word prolonged, how do we settle on a time, like 3 months, 2 months, whatever that might be?
Would anyone like to answer that? I think the problem, which is really well articulated, is that there is no actual cut-off, really. It's a continuum. And so we need a definition that's actionable and that is consistent. And the WHO definition has adopted around 3 months, and that's probably where we're starting from at the moment, because we have to operationalise something. That's not to say there isn't a very significant degree of disability which slowly improves in the month to 4 months following COVID, and that's variously been described as post-acute COVID. The UK definitions actually do include that, and maybe that's something to be considered by this committee or group of experts that can be set up to facilitate a more descriptive diagnosis. But I'm very happy if anyone wants to comment briefly. Yes.
If you wait too long, secondary effects such as fear, frustration, depression start to cloud the picture, and you miss the opportunity of early reassurance and supportive care.
Yes.
As a parallel in mental health with acute stress disorder and PTSD disorder. I mean, you don't necessarily have to do nothing before you get to the threshold. What it means is you do something different, often a much more psychological first aid. So even though it's 3 months is a bit kicked down the track, it may be that the first 3 months is a time for education, GP, support, see how you go, reassurance, get better. So even though it's arbitrary, it's not a bad time for differentiating between those who are going to progress with a little bit of support and education and those who need something more concrete. And I think that's been showed with the acute stress disorder PTSD problem.
Thank you. Any more questions?
Thank you. I guess for us, from a parliamentary perspective, anything that we do when it comes to the reporting has an impact for people on the ground, and we're hearing from people right across the country who struggle to get diagnosis, go to their GPs don't want to diagnose them, don't really know what's going on. They get sent to one specialist, get sent to another, get sent to another, get sent to another. And even people who have experience in the medical system as doctors are struggling to get diagnosis, let alone people, I think about people in my own seat in Western Sydney who don't have this expert understanding. So my question is around, is a definition going to make a real difference to people's lives on the ground? And to Mike's point, I guess if we're relying on a definition, we need it on Monday, because this report is getting done. So that's my question to you. The theoretical to the pragmatic that actually makes a difference.
I think that goes to the concept of a sort of model of diagnosis and a model of care. So I agree there's lots of GPs out there who don't know what to do and therefore don't do anything or refer on. And so I think the definition and the model of care in a very simple manner is a really important thing for primary care. And that's where I think it has to start. It has to be in primary care.
I'd just like to comment that...
Sorry, could you say your name?
I'm a primary care physician, but there's a lot of really good models of primary care that are currently in evolution and best practice that are working on the ground, and then developing that continuum of care. So number one, validating people's symptoms. And people don't present saying, I think I've got long COVID. They present with distressing symptoms. So it's important to engage with it, think of it, and then follow them over time. And a lot of them need a bit of guidance from best practice models of what tests to do when, and then how to then refer if things evolve. And often they are evolving. So in trying to help the patient, the new symptoms will evolve, and then it will become clear when to refer them on to specialists. But ultimately hold the whole patient journey and work with specialists if necessary. So I think there are some really good models of primary care out there now, and we could get some guidelines and some best practice thoughts out there. And number one, validate the symptoms and work with them.
So your question really goes to educating the workforce, at the same time making sure that the clinicians, not just medical practitioners, the other clinicians too that are looking after these patients, are educated in long COVID. And that probably is something, Lena, that the college is thinking about, but it needs to be operationalised, and there's special implications for rural and remote people, of course. I don't know if anyone around the committee works in the rural or remote setting and would like to comment further on that, or if not, Martin, you've had some experience looking at different communities and impacts. Not really?
Well, me, Martin, we haven't really looked at the differential impacts. No.
Okay.
One of my colleagues in the rural and remote areas had to have a round table of all their allied health and primary care practitioners to devise what they were going to do about this issue, because there isn't anyone to refer to. So there are some real service implications in rural areas, but again, bringing people together using the support structures we have, like through primary health networks, and having that platform to bring people together to work out how to solve those problems locally is important.
Announce yourself, please.
Andrew Lloyd. One special item that might fit well with the committee's brief of an actionable item would be, as Dr. Freelander had suggested previously, that the Medicare rebate item for complex care, I think, specifies a duration of 6 months.
And that's a big problem in primary care. That means the GP has 15 minutes to make the long COVID diagnosis, which is not enough. And so broadening just that definition down to 3 months would actually facilitate good care.
Even earlier.
Even earlier, potentially.
I was going to say to Margaret Howard, to add to Alex's point, you might go, if you've had symptoms after a month, you might want to be engaging early to say then the 3 months is your definition of long COVID.
We do have someone online who wants to comment. Could you be very brief, please, because we're a little over time.
Hi, it's Christy Crooks. Just when we're talking about equity and operationalising the definition and data collection, we also need to ensure that everyone's counted. It's important that the Indigenous status question is being asked of every patient, every visit, every time, and that it's all available on all pathology forms so we can accurately collect data on First Nations people, because we know it's not routinely collected and it varies across jurisdictions. And also the measures used to gather data for long COVID will systematically exclude First Nations people. So for many First Nations peoples and families, illness is really is often normalised, and they might not recognise that they have long COVID and therefore won't seek healthcare. So lots of First Nations people won't be diagnosed.
Thanks very much, Christy. Very final comment on this question from Phil. Announce yourself, please.
Phil Britton. Super keen to echo all the comments about primary care being the focus of the upskilling and education programs and guidelines. But I also think that we do need to provide substantial resources for self-management that are patient-focused. The UK has put a big emphasis on that. They have a fantastic resource that is community-focused, that provides excellent information, and at least in my experience with families, that has been by far the most helpful resource. But there's still a challenge that it's from the UK. People feel uncertain.
Okay, thank you. Are there any more questions from the Parliamentary Committee?
Michelle's good.
It sounds like, we almost need a living guideline for this, because this is obviously an evolving field. I think I agree with you. We need a pragmatic definition and we need to get going on that. I'm a little concerned with this algorithm because I feel like it's going to drive a lot of specialist-driven care and an over-medicalisation of this problem. So I can see patients are going to end up getting a battery of tests which are not necessarily going to yield anything, and in fact just lead to more delay and more out-of-pocket expenses and more trips to hospitals. And actually, when you're sick with long COVID, that's probably not great for you to be doing anyway. And that's the feedback we've received from a lot of patients. So I think this algorithm needs a little bit more thought. That's just based on feedback. I guess my overall thing is that, we have a huge problem. There's probably already, I think, and maybe Jody can comment on this, maybe 500,000 Australians with long COVID. We don't really have a handle on that. So we desperately need scalable, equitable solutions that are going to work in regional Australia, remote Australia, and even metropolitan Australia, being aware that there are GP deserts within metropolitan Australia where you can't even get in to see a GP for weeks on end. So I guess I'm speaking really towards self-help tools, digital tools, things that are already being used in the UK, for example.
Which is a little bit about what Phil, I think, was alluding to as well. You had a question. We probably need to wrap up with this one, but if there are outstanding questions, we can take them on notice.
Well, hopefully this is a yes or no. Dr. Koch, you said you were talking about diagnosis and because it's rapid antigen and whatever. Is there a blood test that will show that you've been exposed to COVID in any sort of form or not?
Yeah, so that was the serology test that I was alluding to earlier. In the first few years, particularly before widespread vaccination, we could measure the nuclear protein antibody. You just collect blood from anyone and you measure that. And if you did have antibody present, then you would be fairly confident that that person did have COVID and was infected. And the negative predictive value of that test is extremely high, so well over 95%. So the unfortunate issue is that this point in time, unfortunately, the sensitivity of that test has dropped. So if we did the test today, we may only pick up 80% of patients who've had COVID, but do not mount, 80% of patients mount the response, but the 20% don't
Okay.
in the blood test.
If you're, you might need to take this on notice, but if you've got long COVID, you have that autoimmune something going on, would you, in that case, be likely to show in a blood test or not?
So I should sort of add to that as well that the antibody response is not necessarily lifelong.
Okay.
You do lose that antibody response, so
Okay.
that could happen several months after the acute infection. And the final point is that there will be a subset of people who are infected with COVID who, irrespective of that 20%, just do not mount a response. And the typical ones are the immunocompromised patients.
Okay, thank you.
Monique Ryan's online. She just wants to ask one question, if that's
Okay, sure.
Monique?
Oh, sorry, Mark. I think my question was pretty much covered. I was going to ask about I'm sorry I was absent this morning, but I was going to ask about the extent to which we're capturing data on Indigenous populations, but it sounds like we're not doing that particularly effectively at this point.
Yes, and that really merges into the next session, I think, Dr. Ryan. So perhaps we could move on to the next session. As Dr. Freelander indicated, we've modified the agenda this afternoon, but on the knowledge gaps that were fed back from the expert group, there are a couple of the issues that we did define, Mike, that are important to look to, and particularly looking at the prevalence and burden of disease and the natural history of long COVID. But trying to understand the extent of the disease is really critical, and that goes to acquisition of data, the sources from which it's obtained, the accuracy or completeness of those sources, etc. The other issue that was raised was looking at the gaps in relation to treatments and interventions. So not just drug treatments, could be vaccination or other interventions which are not related to medications, which strategies are optimal and which are most effective. I won't go down the complete list here because we have discussed a lot of the rest of them. But let's pick up those two knowledge gaps. Is there anything that the expert group would like to raise in relation to those two issues? Yes, Michael. Please announce yourself.
I think we'll probably talk quite a lot about clinical data and healthcare data systems as we go through, but I'd really like to emphasise Australia is now unusual amongst our peer nations in not having a population survey of the prevalence of long COVID in the community. And I think we really need to do, not as a research question, as a public surveillance question. The obvious agency to do this is the Australian Bureau of Statistics, and you were talking about the potential to mobilise resources. They would need resources to do this, but in the UK, the Office for National Statistics has been measuring community prevalence of long COVID for nearly 2 years now. We can learn very rapidly from their experience, and with the early definition, actually really quickly convert the UK experience and get something moving to give us real-time information on what people are reporting. Now, that's different from biomarkers and things, but that would give us deep insights and also get a handle on how many people are, suffering but perhaps with a milder illness versus how many people are really severely ill, facing disability, big limitations, etc. So I think that's extremely urgent that we get that moving, because without that population data, we will still be in the dark for at least another year about the actual prevalence in the community without such a population survey.
Thanks, Mark. It's really important. Jodie, please announce yourself.
Jodie McFernan, and I promised Martin and I did not discuss this earlier, but that National Statistics Survey, and these have been, postulated to be undertaken in Australia and have been under discussion, it's not just also measuring long COVID, but it's actually what is the current burden of acute COVID. How many people have it? We know that, case ascertainment testing has fallen. It's not just that we're going to rats, it's that people don't show up for testing. So how do we actually know how that's varying over time? How do we get a population level denominator on new variants that are coming into the community? How do we understand whether people, based on their recorded sequence of prior infection and vaccination, are more or less likely to develop long COVID after a documented exposure in these surveys? And we have relied on extremely rich data on this time sequence of exposures and outcomes from the UK to inform our national policy. We actually have a very different population. We didn't have those early waves. We've had predominantly a vaccinated population exposed to Omicron and subsequent variants. And, we can extrapolate, but we really don't know in our context how those things play out. So it's, as a modeller, it's the ability to say, I actually know where we are in the infection epidemic right now. That lets me also think about what are the different time-varying lagged outcomes in the forms of different types of long COVID that might occur in identifiable future horizon time window that have resourcing implications for the system. So it's all of that information together to inform the next 6 months, 12 months and, over time longer.
Margaret Hallard, I totally agree that we need to have a measure like this. I also think that this is where it gets down to being critical as to why we care, because I think then it makes a difference to what questions we ask the Bureau of Statistics or whoever it might be to ask it. So, and I think it's one of those things that we still haven't nailed in Australia yet as to why we care about long COVID. Do we care about long COVID because it impacts on me going to work? Do we care about long COVID because it's overwhelming our health system? Do we care about long COVID or COVID or whatever it is, for what reason? And I think it's really important that when we put that into the field, we're understanding why we're measuring something and how it's going to be used and whether or not anybody's going to take any notice of it. Because I think that's critically important when we come to it, because there's things that we know that we're not using and there's other things that we're not measuring and we don't know whether that's anybody's really going to care. Do people really care if people take time off work or can't get childcare or can't do this or can't do that or can't play sport? Which is the bit we care about?
Dr. Ryan, I know you wish to say something, but we'll just finish with the committee and then come back to you if you like. Okay. Andrew, very quickly.
Andrew Bailey, I'm just curious about whether people are thinking that this would be an extension, say, for example, to the ABS household impacts of COVID-19 survey, for example. Is that the sort of thing you were thinking, Martin?
I can say that having spoken to the ABS, they saw it as a parallel exercise,
right.
that was something they could get some information from, but they had also been talking to the ONS.
I would agree. I think it's a parallel but different thing.
Yes.
Anne Holland. Could I also make a bid not only for measuring prevalence but also recovery? In our long COVID service, we do follow people up at 6 and 12 months and find that a substantial proportion of people do improve over that time. And there's a small but important group of people who have persistent symptoms in the longer term, past 12 months and beyond. So I think that's also important to understand, particularly if we're talking about a tiered system where we have management in general practice with supported self-management and good resources, and a small group of people who will need complex care in perhaps a tertiary environment. So understanding those proportions would be important. In terms of treatment, I think there are two areas that we do need to address where there's substantial gaps. One is around the role of exercise rehabilitation or graded exercise therapy, and our people with lived experience might want to comment on this one. So certainly there are people for whom those graded exercise therapy interventions are not helpful and can be harmful, but there's also, I think, a group of people with long COVID, perhaps with persistent respiratory disease, in whom those interventions are actually quite helpful. And teasing out that is going to be very important in terms of getting safe and effective care to the people who need it. And I think the other area is vocational rehabilitation, and this gets back to the point about return to work and what do we care about and why do we care. I think what we're seeing at the moment is a large group of people of working age who are reporting persistent symptoms and are unable to go back to work and study, and we do not have good mechanisms at the moment or accessible mechanisms to support those people, and the most effective way to do that is not yet clear.
Thank you. Any other comments? Yes.
In the absence of data,
identify yourself.
Dennis Lau here. In the absence of data, I would like to share from about 280 long COVID sufferers. Just to say that half of these people are unable to work. They have lower health utility as compared to people with diabetes and COPD. And also, a lot of them have seen more than 5 doctors before getting diagnosis, and they spend more than $550 a month on their medications.
Thank you very much. Have we spoken to the issues raised, or would you like a little more discussion on treatments, which was the other area?
I think what we'd like is some outline of a plan of management. Would be very, very helpful. And I've been listening intently to some of the concerns, but this morning when we had a number of patient advocates, they expressed a lot of concern about, number one, diagnosis refusal, waits of up to a year to get into long COVID clinics, and no ongoing management through the primary healthcare system. And we have to come up with solutions to this. So I'd be interested in the panel's view, particularly from people who are in primary care and who are running long COVID clinics, how we can manage this sort of nexus between primary care and long COVID clinics. Some people are making the assumption that we can open long COVID clinics everywhere and there'll be free access. Some people are making the assumption that it will be only primary care that people get access to, and no one suggested in any really constructive way how we can get people in rural and regional areas and in Indigenous populations as well to support. So that's, if I can make a statement, that's what we're really interested in, and a little bit in the dark as to how we can do that. So
Thank you very much, Mike. I think we're really moving into the next session, which is how we can address some of the gaps. So perhaps we can pick up as if we are in the next session. There were 3 people with their hands up, and then Julie, and then our lived experience representative. So someone from over here wanted to... Yes, Andrew.
Oh, it seems to me that there are knowledge gaps and there are...
Please identify.
Oh, Andrew Baker, sorry. It seems that there are knowledge gaps and there are implementation gaps. And I think we need research solutions to both of those.
Sure.
And I guess we have a health services research problem. How do we get the knowledge we have already out? It's going to be more than education. I think we can see that we've got some really good guidelines from the College of General Practice already, but getting that out is a story in its own, and it's an implementation science story where we have some research capacity to help with that, I guess, designing scalable models. And I guess what was the other point I was going to say? While I'm pausing, I'll shut up. Remember the other point I was going to make.
Please identify yourself.
I'd be interested for Lou to comment on this, but to cut to the chase from someone who's been working within a clinic since 2020, you provide validation, you provide an ongoing therapeutic relationship which doesn't abandon the patient in the face of inability to make them better and tolerates the frustration of them not getting better. You avoid over-medicalisation and sending to multiple specialists in the aid of... You have to acknowledge that essentially, I know you'll hear different opinions, there are no effective treatments. The hero ingredient is in fact the exercise physiologists. And I totally agree that we need an online program to start with, both for the general practice to log in, to start off with that, general information, do that, facilitated by the GP. But people talk about care and treatment as if they're the same thing. What people want is to be cared for, in other words, to maintain a relationship with someone throughout their journey and not to be partitioned off. In fact, the treatments in this domain are quite limited now. In 5 or 10 years' time, maybe that will change, but we need to acknowledge that mostly we're helping people deal with an awful event that isn't getting better. One addition to that is that I do think there is a psychosocial element to this, the kind of occupational problem, and Lou and I have joked about long COVID keeper. Actually allowing the employers to support their employees during that period of recovery would take away a large bulk of what we hear from the people outside of their not getting better, is that fear of they can't put bread on the table, they can't keep their job, their role. So rather than molecules, it actually may turn out to be some extension of focused sort of employment support is the most effective thing in the short term.
Yes. Yes, you want to comment?
Yes, I think that...
Identify yourself, please.
Sorry, yes, it's Lena Sanchi here again. I think that there are really good models, and I think the lack of definition and the ambiguity we're learning about today is affecting the profession in general, that once we settle that this is a thing and we get it out there and the guidelines implemented and supported, that will be important. I think that from my experience talking with GPs who are actually running their own long COVID clinics, they're speaking with patients at around 8 weeks, the patients start to come in and they'll say, wait till 12 weeks and see if you get better, and around a quarter of them do. And then when they don't get better, then they come in and they do support them through this journey. But I think possibly what we're seeing is general practice at the moment around the country is under strain, and it's very hard to get appointments in general anyway. There's lack of support for this really biopsychosocial model, supporting that integrated model of care where you can work with allied health and exercise physiologists and those sorts of things. And the GPs that I'm talking to are actually spending a lot of their own time ringing employers and trying to get better conditions for their patients, ringing health insurance and advocating for their patients. And so not all practices are going to be set up to do that. So there is a lot that the primary health system has to do now, the government can do to support primary care to do this integrated work. And where that's available, they will be using these allied health and taking appropriate tests and walking with their patients. But so there's a variety of things at different levels. If we had resources for self-management, that would be fantastic, because there is an element of the population that's doing that. We have clear instructions for GPs that it exists and this is what you can do at the various phases, and then models of care, what you do when symptoms aren't resolving and you need to involve a multidisciplinary team and appropriate sort of item numbers to support that. So I think they're the sorts of things we can do now actually at this point.
Great, thank you.
Martin.
Martin Henshaw. So we just had the Strengthening Medicare Task Force report, which at its root is about delivering new models of care and financing for real integrated care. Here we have effectively a new major burden of disease, the care for which, as we're talking about, is all about quite complex, integrated across the system. This, if we flip it around, long COVID and post-COVID care is an extraordinary opportunity to design something new that really integrates parts of the system, mobilises resources from the private sector in different and new ways, and lets us maybe look at funding models in quite different ways. And it could be a really good test bed, actually, then, if we can make it work for this, perhaps that's something we can really learn from for other chronic conditions. So I think it is both a challenge and an opportunity, but it needs really new approaches to care coordination, which can mobilise resources from state and territory, public hospital systems, from general practice, from the range of allied health professionals, and from the private sector more widely.
Thank you. Julie.
Julie Lesk. In terms of knowledge gaps, you've heard from patients, people with long COVID, and we've heard from clinicians, and they're very useful, important insights. And I want to make the case for a systematised look at the experience, the lived experience with long COVID that is a research-based one that involves talking to people purposively selected. So people across many different sort of strata, include not just people who are accessing care, but those who can't, people in rural and regional areas. That will be very useful from both a qualitative and quantitative perspective in getting a richer understanding of the many ways in which long COVID is affecting different people, including those with a voice and those with less of a voice. And then that will also enhance the excellent ideas that are being shared about treatment pathways, just get systematising the hearing of the patient voice.
Maria, you wanted to comment?
Yes, I just
Please identify yourself.
Maria Crotty. I just wanted to support Martin's position that we do need a sort of new model, and it is a terrific opportunity. I also want to just emphasise that we do have a problem with rationing of access at the moment. There is an ambivalence about it, which perhaps will be helped by the diagnosis. But, you know, WHO does have a position that rehabilitation and access to rehabilitation and the ability to get as much recovery as you can is a human right. And I do feel that if we take an approach where we look at outcomes that are actually quite specific outcomes, you know, like return to work, return to integration, a focus on disability as we intervene, these new models, you know, it could be a terrific opportunity to try something different.
Agreed.
One more comment. Yeah.
I'd like to echo Alex's comment, Dennis Lau here, regarding exercise training and exercise physiologist input. But I'd like to also highlight that two of the most useful medications that I use to treat autonomic dysfunction are not on the PBS. So that means that these are patients who are out of work. How are they going to pay hundreds of dollars for medications to treat their condition? So I'd like to perhaps get the committee to think about that.
And just one more comment from...
Sorry,
I'm sorry, Mark.
Could you let us know what those medications are?
The first one is ivabradine, which is a tablet most useful to slow the heart rate in patients who have problem controlling that. The second medication is a vasopressor called Midodrine, which is about $120 a box, not on the PBS. Ivabradine is about $60.
Do you know if there's applications for them to be listed or not?
No. There are. Ivabradine is on the PBS to treat heart failure, but not for autonomic dysfunction. Midodrine is not on the PBS, and the manufacturer hasn't put in the application for PBS listing.
Could I ask Penelope now to comment from the consumer representative point of view?
Yes, please. So I have one comment about models of care and one about clinical knowledge. First of all, with models of care, I'm not going to read them out, but the Consumer Health Forum consulted with consumers. They put in a submission to the Long COVID inquiry, and their recommendations, which is a fairly short list, predominantly lists the models of care that consumers have identified they are seeking. And I'd suggest that if models of care are going to be investigated under translational research conditions, that priority is given to those models that consumers have identified are their preference, that they believe will best help them. Secondly, in terms of clinical knowledge, one of the huge gaps is that there's quite a lot of long COVID research going on around the world. Most of the studies, if they're large, they're a single study. If they're otherwise, they're not large studies, so they're not translating into something that we would be perhaps comfortable putting into standard clinical guidance here in Australia. But the urgency with which we need to invest in research for those treatments is huge. And I'm going to give you one example because it's critical. There's a 300-person study that made progress in addressing fibrin amyloid microclots that dramatically improved people's functionality for a very large portion of the cohort using a triple drug protocol. Drugs that are readily available, one of them is aspirin. Australian patients are attempting to replicate these results at home using over-the-counter drugs and nutritional supplements that they import from the United States. We need replication so that people don't have to self-medicate, self-treat with things that have been shown to be very likely to be effective. Thank you.
Thanks very much, Penelope. Final comment from Kirsty, and then I'd like to change the discussion to some other elements to do with specific research. Kirsty.
Kirsty Short. So I think this will follow on into the next discussion. As a long COVID researcher, it's incredibly hard to get funding to get anything in this field, even though it's such a big problem. So I would say very briefly that one tangible outcome for this would be a targeted call for research into long COVID diagnostics, long COVID therapeutics, as well as all the big data stuff that needs to happen.
Thank you very much. Just in terms of some of the GAPS committee and the roundtable folk here, amongst those that were really fed back from a survey pre-meeting also included adequate and sustained research infrastructure, platforms and networks that we really need to conduct some of the things that we've been talking about today, which are to do with national surveillance, but are to do with developing those tests and having biobanks and other things available, having networks, research networks already in place that can facilitate studies that are national. And I'd like to ask Sharon Lewin, if you're online there, Sharon, if you could just speak to some of the infrastructure that you think we need in this context to enlighten the committee, and then invite some discussion from the round table.
Thanks, Tanya. I guess that was the slide that just sort of popped up and popped down was a great summary of some of the knowledge gaps.
Perhaps we could put it up.
Yeah, around prevalence, natural history, and how we might go about addressing that. And I think some good suggestions have come up with regard to a population-based survey, and the need for prospective cohorts, and the need for clinical trials. And I think Penelope just summarised that absolutely brilliantly, that we don't want patients getting home-based brews. We'd like to be enrolling people in studies to actually contribute to the evidence that then can allow proper treatment guidelines and implementation. And that needs to happen across the country, and we're still pretty fragmented in how we do clinical research across the country. In COVID itself, there were very well-organised networks in intensive care, less so in hospitalised patients, and really limited capacity in community-based settings. And I think that's going to be needed in long COVID. I will just add one last thing, and that is that I have run a national network called the Prize over the last 7 years, and the Prize has been recently funded again to continue its work, and the focus of the work will be on long COVID and antiviral utilisation. And in long COVID, the goal is to get a sense of point prevalence, establish a longitudinal cohort, and provide the framework for future clinical trials. I just want to make one last comment about biomarkers. I just wanted the committee to understand that the likelihood of a simple biomarker, a blood-based test for long COVID, I think is close to zero. This is a complex, multifaceted, pleiotropic syndrome, as we've seen. The likelihood of getting a simple blood test biomarker for those sorts of syndromes is very, very unlikely. That's why we need really good phenotypic descriptions and really good cohorts, because that's the only way we'll be able to understand the drivers for long COVID and also interventions. So a prize is relatively small. We've been advocating for much more significant investment in national networks around public health research, laboratory research, clinical research. Lots of work to do in the inter-pandemic period, and still lots of work to do in COVID.
Thanks very much, Sharon. Steve?
Yeah, I just want, Steve Wesley here. I just wanted to echo the national coordination aspect of that, because I think that is something that we have been missing, and we actually did miss during COVID to a degree, even though a Prize did a great job. And I think the other part of that is information sharing, and I think we talked about this during the break, the forced break, in the cancer sphere, it's actually relatively easy to find out which clinical trials are available, and patients can find clinical trials. Patients in Adelaide can go on Peter Mac trials or St Vincent's trials and vice versa. But in this area, and Penelope's highlighted that, no one has a clear understanding which trials are available for which patients and where. And again, with a bit of national coordination, I think that information would be very powerful for patients to know that there are trials they can go on. And that gives hope and often opportunity as well.
I am noting that we've been doing a lot of discussing and people are starting to look a little tired. May I request that you all stand up and sit down again, and we can resume the conversation. Thank you. That's the first and only time any parliamentarians will take any advice from me.
I'm sure that's not the case. We are due for a break at 3:40.
Yeah. So we are due for a break at 3:40, but that was really just to enable you a short break. Yeah. So in terms of other actions to address knowledge gaps, have we approached your question, Mike, satisfactorily? Are there other issues you particularly want us to discuss in terms of research that might inform?
I think that we could all talk for hours about this, but I would like to give the other members the opportunity to ask some questions. Melissa.
Okay.
Thank you. Melissa McIntosh, Deputy Chair. When you're talking about research, have you thought about adding the prevalence of things like autoimmune diseases coming on with COVID or cardiovascular diseases? Because we've talked a lot about long COVID, but there seems to be an increase in these types of diseases due to COVID as well.
Kirsty Short, just to answer from the research perspective, so that's definitely a really active area of research, and certainly this is something that Europe has been really good in investing in. For example, at the moment the EU is running a funding campaign for looking at the intersection between chronic non-communicable diseases and COVID, in particular the role of COVID in onset diabetes, metabolic problems, all that sort of stuff. So yes, it is an active area of research, but it's not an area that's particularly well funded in Australia.
Thank you.
Michelle has a question.
I've just got two. One is really around clinical trials. I completely agree we need clinical trials. There's just a dearth of information, lack of information in this space. My only plea to you would be to really reach into those underrepresented groups and actively recruit, in fact, oversample if you need to, because we have travelled around the country, we have read hundreds and hundreds of submissions, and what is abundantly evident is that centres of excellence, hospitals, clinics are just not seeing culturally diverse patients. They're not seeing them. They're not seeing Indigenous patients. That's not from a lack of these patients having long COVID. They absolutely do have long COVID. There's no reason to think they don't have it. They're just not showing up on our health radar. So if you're going to run clinical trials that we fund as funders, there is an expectation that you reach into these communities and you find these people and you recruit them aggressively into these trials.
Michelle, could I invite a couple of members of the committee to respond to your comment, and in particular Adrian Miller, if you're still online, or Christy Crooks? I think it would be an important perspective for you to reflect back. Adrian.
Thanks, Tanya. Yeah, Adrian Miller. Yeah, absolutely. I couldn't agree more with the idea of aggressively recruiting Aboriginal and Torres Strait Islander people into clinical trials. Clearly lacking in a lot of other trials as well. Look, the issue really is going to come down to how Aboriginal and Torres Strait Islander interpret their symptoms, their syndromic symptoms as well. And that's culturally determined, and I know that's not going to be an easy thing to do or to define within a clinical kind of context, but it's really important that we get to understand this as a really important way that Aboriginal and Torres Strait Islander understand, interpret, and actually explain their symptoms within that syndromic space. I think that's really a critical message that I'd like to share with you all, that this Aboriginal and Torres Strait Islander people understand and interpret the world in a cultural dimension, and that means how they explain their pain or their symptoms needs to be understood within this definition as well.
Thanks, Adrian. Christy, did you want to add any more?
Yeah, I was just going to say that often EDs and hospitals are a culturally unsafe and racist health point of care for Aboriginal people, so it's a last resort and it's seen as a dying place and they're not likely to go to hospitals. So I think to Adrian's point, we need to aggressively recruit First Nations people to studies, but then we need Aboriginal people at the table as well in making decisions around what research is being done. So we need culturally appropriate governance structures in place to hear the voices of First Nations people when we're talking about research, and that research is evaluated and interpreted by First Nations people. To just go on to what Adrian said, we interpret things within a different worldview, and that needs to be honoured and respected.
Margaret, please identify yourself.
I wanted to affirm that and note, as a person that does a lot of work with communities where we deliberately go for overrepresentation of culturally and linguistically diverse people of Aboriginal background, it costs more money. And so and because of the way one samples, I'm not going to be really boring about it, but if you actually want to have good data, you have to be prepared to pay much more for that piece of work, be it a cohort study, clinical trial, whatever it is. And to Kirsty's point, you have to make sure you have community engagement with the affected communities so that they are actually articulating how the questions need to be asked, and that applies to many of the communities. They think it's thought about differently, so therefore at the very beginning of the design of the piece of work there needs to be a co-design community component where it's done seriously, and that also costs you time and money. And you have to acknowledge it. If you want that, you have to be prepared to pay for it. And that's MRFF calls or whatever calls they are, and it has to be proper amounts of money and not $12.03.
That might be all we have.
Yeah.
Sorry.
Christy, and then a brief comment from Penelope and Michelle.
Thanks, Chris Crooks. Just on that, we've just got to make sure that we have a way or a formal mechanism for evaluations or any research trials to be fed into government, to be taken seriously, and to be considered to implementation into policy.
Penelope.
Yeah, Penelope McMillan. I couldn't agree more with all the recent comments. I'd like to put in a plea for two additional groups that are often overlooked. Firstly, people who are not engaged digitally. The evidence suggests 40% of Australians are not active online. They get left out of surveys, they get left out of consultations. We need to, as was just said, we need to cough up the money to put the effort in to reach these people, and a lot of them they're overrepresented in rural and remote Australia. The other group is frail, homebound and bedridden people. We know that in Australia before COVID, there are approximately 600,000 people in Australia with disabilities who rarely left their home. Those who are most severely ill with long COVID are at home. You don't see them in your research centre, you don't see them in your medical clinic. I know people with long COVID who have been confined to bed since their long COVID for months. You are not going to see them unless you go to a great deal of trouble to fund outreach for your research, for your consultations. These are people who need support to communicate, but their needs are really important. Their carers have a lot to contribute. So people who aren't engaged online and people who are homebound, they're hidden and they mustn't be.
Thank you, Penelope. Sharon, you've been patiently waiting. Did you want to make a comment, Sharon Lewin?
Thank you, Tanya. Yes, a few comments. I was going to just make a response to how we calculate the issue of poor cardiac outcomes, renal disease, etc. And in the AIHW report on long COVID that was circulated in advance of this meeting, which I think was excellent, they did talk about data linkage studies that are now starting and happening around Australia. That's the best way to really understand whether there is an increased health burden and the degree of that health burden and where it's happening. It's challenging now because of the difficulty with COVID diagnosis, but it is happening. And I think that needs to be reported more publicly. So we would tackle that differently from point prevalence surveys. And just Michelle's comment about the clinical trials, couldn't agree more. I mean, there's ways to build in incentives around recruiting into specific populations. You know, the NIH do that really well. We traditionally haven't done that in Australia, where clinical trial funders require that you have X% of certain participants, and perhaps that could be an initiative. And if I could just say one last thing, most of the funding that we did with COVID, and there was additional quite a bit of research funding coming in for COVID, was done in the usual model, meaning breaking people up into small groups and competing with each other. And there we got a whole lot of small studies and nothing cohesive. So I could just make the argument for big challenges like this, we need strategic funding that bring people together, not break them apart and allow small groups to compete against each other.
Thanks very much, Sharon. Michelle, have you had your question?
One more.
Pardon me, Dr. Amanda
This is the
Raja.
last comment. I just a plea for implementation science. I was really pleased that Andrew raised this because I've been banging on about it in these corridors for since I came, and I think it's really that last mile that we neglect in research. So we tend to create all this wonderful knowledge, and then we come up with a policy guideline and we tick off translation and we say done. And if that's where we stop, then we are doomed to failure. What we really do need to now invest in, and I'm advocating for this actively as funders, is that last mile of implementation research where we actually take those guidelines and we embed it at that front line so that your GPs at that front line or in a community centre in Cairns or in the Torres Strait or wherever knows exactly what they need to do. And we are not doing that right now. So that's something I would like the panel to deeply consider.
Any comments to reflect back to Michelle before we ask Dr. Freelander if there are any other members of the committee who have questions?
Yes.
Right,
Julie Leask. I just want to echo that, Michelle. There's no point in doing fabulous research if it's not used. And there is a field called implementation science, as you know, that is a formalised, helpful way to make sure that interventions that have a good evidence base are actually taken up. And that is research as well. And that needs to be funded along with the surveillance and the diagnostics and the biomedical side of it. That also needs funding.
Thanks. Yes.
Jeremy Nicholson. Yeah. Most of my experience in translational medicine is from Imperial College London, so I apologise for English. But there is nothing equivalent to the National Institute of Health Research, which we have in the UK, which is directly designed to couple fundamental research with NHS. And my old department, half the members of staff were NHS doctors as well, being members of academic staff. There is money already in the UK system for translating research findings, and Australia desperately needs to have that. And it's not just for COVID, I think it's right across the board.
So I think that's a really important issue we can pick up in the next session. So thanks, Jeremy. Did you want to comment?
I do.
Please identify yourself.
Brendan Crabb, and look, in support of Sharon Lewin's call for thinking big and cooperatively about funding around these challenges, and with respect to biomarkers that both Sharon and Kirsty have spoken to, I absolutely agree that we're very unlikely to have a simple rat test type thing for long COVID. But don't misunderstand how important biomarker research still is. Absolutely crucial. It sounds like a niche area, but it's actually about underlying mechanism. You learn an awful lot about what's going on. Underlying mechanism may not nearly be as complicated as clinical syndromes are. And so the idea that we learn a lot more, we end up having tests that can rule in or rule out and greatly help the sort of guidelines that Andrew spoke about right at the beginning, because you've got low cortisol plus X or whatever. These sorts of things are going to make a big difference to our understanding and also to diagnostics. So grand challenge type activities, not just simple calls, but really ambitious calls. Research done here is very, very important. Don't wait for it to happen overseas. Do it here so that discoveries can be made here, but also translation of stuff that does happen overseas can happen very rapidly here.
We have 4 minutes left in the session. Is there anyone else?
There's no further questions.
No, so Phil, would you like to comment?
Phil Britton. My comment is really because I feel the burden of, I think, being the only clinical paediatrician in the room, notwithstanding the fact that there are 2 clinical paediatricians on the committee. But I really do want to advocate that in terms of oversampling, children do need to be considered as a subgroup. It will be different, particularly in young children. I've previously made that point. But also, and I'm banging on, that the developmental and growth and learning trajectories are established early in life, and so the burden of disease, even if it's less prevalent in children, has a long-term important outcome. So I just want to advocate for the inclusion of children.
We do have one other person online, I think Craig Anderson, who's not had an opportunity to comment. Craig, are you online and would you like to make a comment? There is someone who's actually showing their face online, but I can't actually see who it is. Oh, it's Adrian. Okay, Adrian, did you want to make a further comment? No. All right. Are there any final comments or questions from the committee before we break for afternoon tea? Very briefly.
Andrew Bailey, I just wanted to make a comment that we have some really great examples of agility and research that really delivered for our society in acute COVID. We have long-term investment in public health research, and that research workforce was able to be reallocated and really was part of the powerhouse of how we came up with an absolutely fantastic world-leading response to acute COVID. What we're seeing here is we just don't have investment in research workforce, in chronic disease, and in a way it's coming to bite us. And I think we, in addition to the implementation work, in addition to the knowledge translation questions we have, and Martin's fantastic point about the opportunity for models of care, to have an intelligent local solution, we need investment in a chronic disease research workforce.
Thanks. Sorry, but Christine McCartney apparently wants to make a comment.
We have had two members join us after being at another committee. One of them is Professor Christine McCartney. Christine, would you be prepared to make quite a brief comment, please?
Thanks, Tanya, and thanks, everyone. Look, it was just to reinforce what I think Sharon Lewin was saying. I mean, we really need a wider research strategy here, and we need multifaceted research, program, not just in a long COVID, but that brings things together in a way that is efficient and effective. The government of Australia and the state and territory governments are investing a lot of time and effort into linked data assets as just one avenue, but we don't have an overarching strategy about how to use those effectively. Now, that's not the only avenue, but that's one avenue where you can look at the whole population and at least garner quite a lot of information that way, including around preventative strategies, which include, of course, antivirals and vaccines. So we need that. I mean, and I really just wanted to pick up on the other comment about being able to address through a sort of more bio-psychosocial model all the other avenues in research. Thank you.
Thanks very much, Christine. And on that note, I think we should thank the committee very much for the questions and engagement and break for afternoon tea. And coming back at 4, so I'll flick back to you, Mike, for any final comment.
Thank you. We'll pause the committee meeting now. There's tea and biscuits over there, and bathrooms, if you go out that door along the corridor, male and female bathrooms, if you want. So we'll pause as of now. Thank you.
Thank you very much.
And we will come back at 4 o'clock.
Thank you very much, Dr. Freelander. We're now in a session where we're hoping to bring together and consolidate ways forward on the basis of the previous sessions, with asking how government, the research and health sectors can work together to deliver those actions. And I'd ask the Secretariat to bring up the first slide, because I think it is of value to look at the feedback that we received from the survey conducted prior to this meeting, but also ensure that what's indicated there has been or has captured what we've discussed thus far. And so, slide please. Oh, right, okay. The actions we've tried to crystallise into 3 different areas. One is clinical care and communication with the community. The second is research and evidence into policy. And the third is coordination and harmonisation. So we take each of those one by one. The first one, under clinical care and communication with the community, is to establish evidence-based models of care and social support. Secondly, government and health authorities to improve communication approaches, including for special groups such as those who are culturally and linguistically diverse and First Nations people. And then the third issue is really to ensure that there are adequate information resources and guidance for both patients and healthcare providers for these diseases, and to ensure that the community has an understanding about them. So this section is now open for discussion, initially by members of the round table, and then any brief input from the Parliamentary Committee. Would anyone like to open the discussion around clinical care and communication with community? Steve. Oh, I'm sorry, Margaret.
I would just like to sort of have a discussion or maybe think about how we frame it. To improve communication approaches seems a one-way thing, and I think it's really critically important that when we're talking about working with community, we talk about engagement with community and understand that what we mean by that is that the community is part of identifying how we're going to solve some of these problems. And I think this is critically important for First Nations and people from culturally and linguistically diverse backgrounds. But so to me, I would like us to really think about it in a much more fulsome way than just a communication issue.
So how would you like us to frame that as an action?
So I would say that it needs to be engagement with the community through co-design approaches to work being undertaken.
Thanks, Margaret. Yes, Alex.
I've spoken
Please
a lot.
identify yourself.
Alex Holmes. Look, I'd like to extend this to the widest community because I think stigma is external and internal. And our experience, you've got the physical symptoms, which is you can't move, and the first person who hammers down on you is yourself. And then after that, there's some sort of support in the community, but over the time there's some negative community reactions to, not being able to do what you used to do, which is sort of one side of the Protestant work ethic. So we need to acknowledge that the community's response to people who don't function in the normal roles for significant periods of time is part of the problem. So not only do we need to educate the health community, but the wider community in a way needs to revisit how it approaches young people who can't function, and rather than you're a mug or you're a slacker. So I think that there's a sort of broader community discourse needs to occur about, how do we understand people like this, and that's necessary because I think unless it happens, those attitudes feed back into the people's experience, and all the clinics and GPs in the world doesn't help if your next door neighbour thinks you're a mug.
So if I interpret what we've heard so far, it's really co-design research that needs to be done with the community, but not just the affected community. It needs to be understood what the impact is on the broader community, which speaks to potential methodologies perhaps that are needed to do that. And I know you have your hand up, Julie.
It was actually, Julie Leask, it was actually about the notion of clinical care and communication I think that the communication, the engagement form of communication is integral. But then there's the education and informing part of communication that is also important, particularly in relation to primary care, GP practice, general practice updates, teaching health professionals about long COVID, what it is and what the treatment parts are. So I think that's the communication piece that relates to educating and informing that is usually a little bit more one way. That's separate to community engagement, which is much more two-way and about listening and co-design.
Thanks, Julie. Yes, Phil.
Phil Britton. I would advocate that one of the things that needs to come out of this committee's work is actually an unequivocal statement that long COVID does exist across the lifespan. And in those people affected, it's burdensome. And I do agree that the non-affected communities in Australia need to hear that message, because there's still a strong message out there that it sort of doesn't really exist. Having said that, the paired message is incredibly important, which it is not. Long COVID is actually not that common, and that most people who've had acute COVID will recover without long-term issues. If you don't pair those messages, and I think it really does need to come as a headline from this kind of committee's work, because without those two messages, I think the health system still won't move forward as if this is a problem we have to deal with, but equally, the community will still look around them and say, I don't know lots of people with long COVID, COVID doesn't make everybody very sick and debilitated. And that's just, those two paired messages need to be clear, unequivocal, and well understood in the community.
Yes.
I think possibly an easy
Who's
win.
announced your name?
Anne Holland, sorry. Possibly an easy win would be making self-management resources widely available in the Australian community. And we've spoken a number of times today about Your COVID Recovery from the UK, which is an excellent, high-quality resource. I think if we could make that available to the Australian population with, very minimal tweaking to make it appropriate to our environment, that would be a huge win, and it would support GPs in delivering supportive care and self-management for those people who need it.
Yes,
Dennis Lau here. I've been privileged to be able to work with 2 specialist nurses to deliver care for patients with long COVID. I can't emphasize the benefits of having allied health professional input in assessing these patients to really cut down your waiting list and to get more patients seen. Most healthcare doctors will be able to see 15, 20 minutes, 30 minutes at best, but this is a complex condition and you need a lot more input in educating, in listening to the patient's stories and in supporting their care. So I'd like to propose that we emphasize that.
Andrew.
Andrew Lloyd, so in terms of actionable items that we're recommending here, it sounds like there's a general public education program that's being proposed, maybe paired with, as Phil flagged, messaging about what long COVID is and isn't and what its natural history is, and reassurance that most people won't get long COVID. Moving into the more pragmatic care of those with long COVID, I do wonder about, or I wonder about what the group think about the idea of what you might call wraparound education. So educate the GP, educate the allied healthcare providers about how to provide care in relation to long COVID, and educate the patient all in the one harmonised education program, and then evaluate its utility.
I think you could do that with self-management resources,
Yeah.
because actually that provides education to everyone about how you might go about managing long COVID.
I'm not sure that all patients can self-manage would be the only trick, but where they do need a team, then this would underpin it.
I think listening to the previous discussions too, it depends on their degree of health literacy, their ability to use digital equipment, and in particular in remote and rural First Nations communities.
But I think there are still a large proportion of people who would benefit from having those resources available, and then it gives us an opportunity to think about tiered care and who needs more than that and how they access that specialist service.
Andrew.
Andrew Bailey, I was just going to comment that I'm not sure that all the barriers are knowledge barriers that education fixes, and I think a more sophisticated wrapper around all these things, understanding what are the gaps and where are is an implementation science approach, but that's the way I would see this. It seemed to me that we are too quick to say we need education when knowledge isn't always necessarily the barrier.
Yep.
Yes, I agree with that. We need education, but the patients themselves aren't at their best at the time. They've got brain fog, they've got fatigue, they've got anxiety, and so possibly the education needs to be also targeted at helpers, carers, other people.
So how are we going to help the committee formulate an action in relation to this, Margaret?
So behaviour change theory goes... Behaviour change theory... Margaret Hallard, sorry. One of the things of behaviour change is you've got to be aware that the thing exists, so that kind of knowledge, that broader communication. You've got to then be aware that you've got to agree that you're going to do something about it, and then you've got to be able to actually do something about it. So it's sort of an old-fashioned... there's much more complicated or complex things, but they're the sort of 3 critical things. Know it exists, believe that it's impacting on you, so that you're not mad, you're not malingering, you're not all of these kind of things, that it's okay that I have to take 8 weeks off work and I've been told that's a good idea, or whatever it might be, and that then you can actually take 8 weeks off work, because there's no point in us saying to people to stay home, don't do this, do that, come to these clinics, do a wraparound service of looking after your mental health, and then you go, but actually I haven't got any food in the cupboard. So to me, they're the things that I think, in terms of recommendations of a broader one and then this wraparound service, but it has to be that it's then actionable by, I think, was it you, Alex, that said earlier, how do we make sure people have got the ability to stay at home if they need to stay at home until they're ready to go back to work? And what does that look like from an actionable thing for government?
So I guess from the committee's point of view, what key message would you need to be conveyed that would assist you with this?
The chair's disappeared. So it sounds like we need to invest in co-design, and maybe if some funding needs to be directed into that. It doesn't sound like we've bedded this down, and it seems to be part of implementation science, that process. Would that be fair? Yeah. Okay.
I'd actually, and if bang for your buck, pinch the British model early on, implement it, evaluate it, do some parallel co-design. But if you want to get onto it early, pinch the British one. Think about some sort of long COVID keeper, short term. This is an early intervention model. Mostly people get better over time, and that's the message. Totally agree. So you're going to say, people who get to the 3 months, they're not kicking goals. What do we do? It's a stepped model, early intervention, GP, maybe specialists for complicated cases. They're going to go through the program. They're going to have maybe some occupational support. And at the end of 12 months, the theory is they'll be better off than if nothing happened. But you have to test that, evaluate that.
I think too what you were saying, Professor Britton, about COVID affecting the entire spectrum of life. I think that's really important, and having that communication from early childhood all the way up to, the geriatric patient population, I think is really important.
Thank you very much for that. We should move on to the next slide, please, which is the theme under research and evidence into policy. And we've obviously talked a little bit about this in the last session, but it's looking to improving access and recruitment to clinical trials, consider a national clinical trials network, which Sharon Lewin articulated, in the context of jurisdictional initiatives, look at targeted research funding for long COVID, which has been mentioned already, support and coordination of infrastructure needed for research, and that goes to biobanks and other things around the issues that Jeremy and Kirsty have been talking about. Look at patient-directed research, consumer research priority setting, look at establishing an evidence base for research which goes to the information and data, look at the maintaining the currency, that is keeping all us up to date with international research efforts, a bit like we do with the national group that's actually looking at clinical evidence for COVID, looking at ongoing mechanisms to disseminate that evidence, sort of having a one-stop shop maybe, and looking at First Nations-led research and mechanisms for outcomes into policy. That's a lot of dot points to assimilate very quickly, and I don't expect you to have done that, but would members around the group like to bring up the issues that you consider we should be discussing? Julie, to start with.
Leask. I've got a question actually. Is this research and evidence into policy specifically or practice?
Both.
Mm-hmm. Thank you.
Steve.
Steve Westling here. Ian Chubb was in the room and he's now left, but he did want me
No,
to...
he's not. He's still there.
Oh, Ian's there. So I'm going to talk for you, Ian. But Ian mentioned that he's been doing some work over the last couple of years of looking at essentially an Australia-wide portal for clinical trials, or a sort of one-stop shop for patients, consumers and doctors to find clinical trials. And I understand from Ian that that's his consultation and his work on that is coming to fruition, and it is going through government, possibly to get funding. But that would actually answer the comment that I made before about how do patients find clinical trials. And this portal would enable cancer patients to find clinical trials, but also obviously post-COVID and other patients. So it's a bit of a plug because there are probably people in this room who can facilitate that process in terms of funding, and obviously it would make a big difference. So just thought I'd mention that.
Thanks, Steve. Jodie? Thanks, Jodie McVernon. I guess I'm aware that there's the corresponding CDC agenda that's being discussed here, and I do think that's a national opportunity in terms of some of these initiatives to coordinate and harmonise. Where exactly that entity sits, what its functions are, it still, I think, is potentially an important national focal point, and in the emphasis on both communicable and non-communicable diseases, brings together perfectly both the risk determinants and outcomes of these kinds of events. So, I think considering the place of such an entity in some of these coordinating operations and how it might bring together networks of networks and help to improve visibility of research and other things, it's another potential coordinating mechanism that we haven't had in the past. So, just raising that. Can I just throw out there, what about an overarching body trying to develop the research agenda? I mean, we have established entities that clearly do that, but they're not necessarily linked together. And I suppose what comes to my mind is the MRFF and the NHMRC, for example. Would people like to briefly comment? Yes, Martin.
So I'd escalate that perhaps straight away if you were thinking of aiming high. I think there's an opportunity here, for those who are familiar with the Mariana Mazzucato mission model, that I think there's a real opportunity for whatever you might call it, a sort of post-COVID care and knowledge mission here. And I'd go so far as suggesting you might even want to sort of ask the Minister for Health and the Treasurer to think about bringing her down to give a little bit of advice on how you would bring together all those research funders, the key government departments, both Australian government, but with an appropriate state and territory representation, ABS, AIHW, those kinds of people, and really work out how to set up, and I wouldn't say how to do it, but to really set up a very high level structure which is saying what resource do we need to mobilise to answer these knowledge gap questions and start doing immediate action, but really looking short term and long term on where this is going, so that all these kind of MRFF, NHMRC, also that are actually in the room where the heads can be banged and actually a fully integrated, prioritised approach can come out of that. Say again?
A single portal for research.
Well, on this, more than a portal, but a real deep prioritisation of what are we trying to do, a real statement of objectives to drive then how the research gets prioritised, with active research priorities driving the funding going forward.
So there are a number of people with their hands up. I will address them all in order. Kirsty, sorry.
Kirsty Short. So just in regards to the MRFF and NHMRC, one of the problems we have as researchers is that the MRFF is very clinically focused and the NHMRC you can do more basic research. But wouldn't it be amazing for this sort of project and problem to have something that really went all the way from basic through to translational, through to policy as a national effort and not siloed off into one research group competing with another, but saying this is a national problem we need to solve. Let's bring all our knowledge, all our skill sets together in one consolidated effort.
Okay, thanks, Kirsty. I can see Penelope. Let me just ask Christine McCartney first, and Penelope then go to you. Christine McCartney.
Yeah, thank you. Look, I really fully endorse the comments, and I think the UK, model and this just much higher, all-encompassing strategy. I mean, we're a relatively small country. We need to be efficient with our resources, and we've got siloed ways of doing things. I think in adding to what Centres for Disease Control can do. In my area at least, everything we do is implementation research. Everything we do is monitoring, evaluation, coming back to what more research we need. And we really need to just embed that cycle in the way that we spend, address health issues in a much greater way. And I think the CDC will help there, but it has to be high level, strategic and absolutely nationally cooperative. Thank you.
Thank you. Penelope, would you like to comment now?
Thank you. Penelope McMillan. I do want to talk about research priorities, but a very quick comment about clinical trial registries. There have been several attempts to set those up in Australia. I'm registered with several of them. Some of them are condition-specific. I'm in a couple of cancer registries. I'm in some general registries. None of them have succeeded. And there is a group of consumers gathered around a non-profit organisation who are very concerned about setting up clinical trial registries that will actually work. And I think if anyone's going to do anything in this space, a bit of jargon for you, in this space, that they need to consult with the consumers who are working on that. When it comes to research priorities, I want to put in a massive plea here. Ask yourself, for whom are these research priorities being set? They did a massive international study with bowel cancer of patients and researchers, and they found the researchers desperately working hard to try and extend the lives of people with bowel cancer. People with bowel cancer desperate for a better quality of life. If you're going to set research priorities, you must consult with the people who are the end recipients of the research, the people who have long COVID, the people who have conditions that are also overrepresented amongst long COVID, who've had many years of experience of not being well served by a health system, so that your research priorities are meeting the needs of the people they're supposed to help. Thank you.
Thank you, Penelope. And I think we've received that message very clearly, and the discussions around co-design very much speak to that. Julie, and then Andrew.
So just to address the question about research and evidence into policy and practice, there are helpful frameworks that guide thinking around that, extending what you were talking about, Margaret, the frameworks that guide implementation of evidence into practice, like the behaviour change wheel, which we find very useful in improving vaccination rates in working with many countries. And in addition to that, there are frameworks for bringing the findings of research and the knowledge into policy change. I almost want to ask the committee, how do we get evidence into policy? But from an academic perspective, there are some very useful approaches like Kingdon's policy windows ideas and others that I think the relevant expertise can advise on.
Thanks, Julie. Lena?
Yes, Lena Sanchi. I want to put in a plug for what we're missing in this country is infrastructure for national primary care clinical trials and data surveillance and data in general. So reaching, unlike the UK where we have the CPRD, it's a really broad platform around the country of research-ready practices that can reach their patients in community. Not only is it useful for reaching patients that might be suitable for clinical trials, but it's also useful for doing the implementation science and that sort of research going out from bench to bedside to community. And we're really missing that in this country, and we miss the opportunity to test a lot of the treatments and vaccines here in primary care where patients are presenting, because we don't have that system, unlike the UK. So we really do need that, I think.
Andrew.
So I wouldn't want to be mistaken for a politician here, but I do have no, but I'd be proud to be a politician. So what I was going to say is that my sense from interacting with international colleagues that are trying to grapple with the same issue is that actually Australia's got a great opportunity. The combination of socialised medicine, relatively good public health infrastructure and good data and reasonably good healthcare systems, we have an opportunity to get that together, both in a clinical and a research sense, in the kind of form of a mission, and that would become widely respected internationally for sure. We'd be looked to for how best to do it, and my sense is it's translatable beyond COVID. And then changing topic slightly, just while I've got the chair, can I just make a plug for biobanks? There is part of the prize endeavour that Sharon Lewin has alluded to, is to make a virtual databasing network of specimen repositories that might be relevant, which would help people like Jeremy and Kirsty that don't have the clinical connections necessarily to get access to specimens. So again, it's an opportunity in that broad infrastructure sense to get our act together.
There is actually some legislation
coming up in the next sitting about bone marrow registries. And,
Right.
So,
Okay, Margaret.
I just
Identify yourself.
Margaret Hallard, sorry. I wanted to emphasise what Andrew just said about the extra bang for buck. If we set this up right, it goes beyond just COVID. And so I think that's critically important in terms of the things that Lena was talking about, but also surveillance systems. And also I'm a great believer in really coordinated research approaches, but you've got to also make sure that we are very comfortable with having people invited into that space who are going to not follow the orthodoxy of thinking. So that's the critical thing as well, as we do these things, that we're very conscious of that.
Okay, thank you. I don't think there are new people online. Pardon me.
Brendan Kraut. Look, just endorsing the notion of coordinating research funds and how that is not a new concept, especially NHMRC and MRFF, but other smaller translational funds as well. That's not to say, the reason they're separate is there's a really important function that needs to be at least conceptually maintained of the different funds, but lacking that overall coordination is a big missed opportunity here, as is potentially the NIHR type activity that the UK has that is missing. And just because I've had so much to do with the MRFF, it has a very conservative disbursement strategy. It's well over $20 billion fund now. It's a $650 million disbursement each year, something of that magnitude. The aim when it was launched was for it to be $1 billion a year, and that is still less than 5% of the fund. So, and interest rates are going in the right direction, notwithstanding some banks withholding giving them to depositors. But I think that there's a real opportunity for very significant funds there. It's an incredibly conservative approach to disbursement that was there for a reason at the time, but it's no longer as relevant.
Let's go to Christy Crooks.
Hi, Christy Crooks. Just on the disbursement of funding, Adrian and I, as part of a prize, led the distribution of $2 million from a prize at Paul Ramsay Foundation. And we funded 11 First Nations-led projects across the country. So we embedded cultural principles that were informed by First Nations peoples on how that money would be spent and shared across different projects. And we prioritised to Aboriginal and community-controlled health organisations as being part of the research project. So really kind of honouring and privileging the community-controlled organisations with that as well, which I'd like to see more of on-the-ground research. And also I've got a declarative conflict of interest, but some work's happening in the background. We've conducted some research with First Nations communities and developed a way to engage First Nations peoples in making decisions about public health emergencies and pandemic and responses and plans. And it's an Indigenised approach to citizen juries, and we've found that they are effective and are a good way of working with First Nations peoples. And we're just in the process now of seeking some funding to run some soon. So that's another approach, but we just need a formalised mechanism to feed the outcomes of research into policy.
Final comments from Alex and then Steve.
Very quickly, look, I'm going to be a bit negative. I've got a concern here. I mean, you've read the article on paradigm shifts and the need to think of it differently. We talk about biopsychosocial. We know that the research people who get the money are the people who are good at getting research money, and that there's lots about the actual program here that might make a difference, which doesn't fit well with research funding as it is. It's going to be long-term, it's going to be biopsychosocial, it's going to be primary care, and the interventions are actually more in the quality of the relationship and the validation and the model than the drugs and the surgery and the things. So my concern is, unless there's some sort of work on the model and saying, this is maybe the big model, a bit like the NIH used to do with the collaborative study of depression. This is the model, and we need to sort of actually, if we're going to test it, it's going to have to be tested this way. You're just going to end up with, testing aspirin against indomethacin or something. But we're not actually going to get a test of what is the major intervention, which is a biopsychosocial stepped programmatic intervention in the first 6 months of post-COVID. So I just like to raise that as a problem for you, not for me.
Yeah, I just want to, I guess, partly because one of the academies here, point out that the Academy actually has done a whole lot of work in this area of implementation and embedding research in health, and Christina Mitchell led a very large piece of work which led to the vision statement. But ultimately what that said was that in order to move that last mile, we do need to embed research in health. It needs to be in health. And one of the ways of doing that is actually getting everyone around the table. And that's what I heard here, that we actually do need the MRFF, the NHMRC, but also federal health, but also state health and primary care around the table, because all of the things we talked about, if we only do them in one state, they're not going to work. If we only do them at a federal level, they're not going to work. If we only do them in the hospitals, they're not going to work. We actually have to do it right across the board. So some sort of alliance, as described in our document, which Catherine is now going to share with the committee, I think could actually be really helpful.
Thanks very much.
Abolish the states, that'll make it easy.
That's true too.
Okay. Did you have any questions from your committee at this stage?
We do have a few questions. I'll go to Monique Ryan first, if I can.
Monique, you're on mute.
Sorry, no, I don't have any questions at this point, Mike. I think I'm good, thank you.
Okay. Michelle?
I wholeheartedly agree. I'm just a little cautious about another bureaucracy. I mean, I think, you've all worked really well today. I mean, can you do this? Can you? I mean, you sit on NHMRC committees, you sit on, MRFF councils. Now that I have a balcony view, as you know, all I see is fragmentation in this country, and it's made us weaker, as Sharon said. It's absolutely made us weaker. So I like the idea of, a not UK NICE types thing, something focused on translation, but I would just ask you to come up with a model that does not cause further fragmentation.
Thanks very much, Michelle.
Thank you. Talking about bureaucracy, in a question, so I've got a portfolio in shadow mental health, and a question around mental health, and the answer was people just need help. That was basically what the answer was. So I guess my question would be to you, Professor Holmes, around your final position on the mental health component of long COVID and what we need to do to make sure that decision makers in this country are taking that seriously.
Taking up Philip's point of view, I think it's in the messaging about you will get better. I think another part of the message, and COVID is real, the third part of the message is this is not a mental health condition, primarily. I think that needs to be said. It's not all in your head. So COVID needs not to be in your head. However, if you can't move or work or do whatever, there's going to have secondary psychological consequences. So we need to introduce the idea of psychological and social consequences of the primary COVID condition as fleshing out the experience. And there's no question in our clinic that some people with predispositions, and even not with predispositions, their anxiety, fears becomes a primary driver of their ongoing disability. But I frame it very much in that secondary framework, and also we have a general principle: avoid any mind-body dichotomies. So you're not allowed to say this is all physical or psychological. You just say this is, part of the patient experience. So, and the last point I'd make is traditionally mental health has been great for physical doctors in giving them a cop-out in terms of when they can't explain something, we just say, oh, it's all in the head. So in a way, I think there's got to be some work done to make sure that mental health workers don't facilitate that particular easy solution to the complex problem of a patient who doesn't get better, because it is a tradition in Western society that we use that, and it generally is not very fair. And in this particular circumstance, I don't think it's no longer tenable. So in practice, there's very little primary mental health problems in COVID, except a bit of reflection on what you're doing.
Thank you.
Anne, have you got a question?
No, thank you.
Perhaps I've got a question to Phil Britton you might be able to help answer. We know that there are cognitive effects of COVID acutely, and there's emerging evidence that long COVID in kids and adolescents has cognitive effects. Are you aware of any research that's actually modelling that and looking at that?
When you ask the question, are you aware of any research you're particularly interested in Australia or overseas?
In Australia.
No, I'm not aware of any research in children and young people that is primarily focused at assessing their cognitive outcomes or neurodevelopmental outcomes of COVID. I will say that one of the reasons why that would be challenging is because long COVID is actually very infrequent in children. So again, I come back to that dual point. You can have something that's infrequent but burdensome. And I think it's really important we capture that. And I also want to suggest that a previous comment I made, which what does long COVID look like in children under 10, is really a wide open space. Very little good studies, particularly studies that have involved close clinical phenotyping. There's some work from the US with large data sets, administrative data sets, but everyone here knows all of the challenges with interpreting what they mean in clinical practice. There's very little close clinical follow-up, neurodevelopmental follow-up, and part of that is that, I mean, I know it feels like it's been a lifetime that we've been with COVID, but it really is only a couple of years. For most children who've been infected, it's under 12 months. And so it's not surprising then that we don't have a detailed understanding of the longitudinal outcomes in children.
Any other questions? Monique, any other questions? All good?
Yes.
Lou Levington. We've done neurocognitive tests in young adults with significant brain fog and haven't found any measurable abnormality except universal hypervigilance, like a cat on a hot tin roof. And that is a manageable, treatable trait. You can actually decondition people to being hypervigilant. So.
Yes, two more.
Follow-up comment, Mike. Andrew Lloyd here. If we broaden the perspective to other post-infective fatigue syndromes, there is already evidence-based that the cognitive difficulties, the brain fog, can be a dominant symptom, and I think that's true also in long COVID. It can be the thing that stops people getting back to work primarily, and also that cognitive remediation is effective. So a kind of a brain training graded exercise paradigm is effective in improving performance, which fits with what Lou was just saying.
Dennis.
Yep, Dennis Lau here. In a lot of autonomic dysfunction patient, brain fog or cognitive dysfunction is a very common symptoms. We have done studies and confirmed reduced cerebral blood flow as a cause. And again, with treatment with medication to slow the heart rate and increase the blood pressure has been shown to improve their cognitive function. So I think it also can be largely due to underlying dysautonomia that can be improved on.
Very briefly, who are you?
Sorry. There's a number of kind of standard measures that are used for how people are in terms of quality of life, all of those things, and often with chronic diseases, they're not fit for purpose. So that you get these quality of life in the standard population, and then you say, I'm going to apply them to people with other health issues, and you see no difference in terms of an acute thing because that's not what they're good for. So in fact, a lot of the measures that we talk about when people say, we see no difference between this and that, they're actually not well designed for that. So I just also want to have a level of caution when you look at data on that.
So the third component in this session, which is really slightly over time already, was around coordination and harmonisation. I think some of the potential avenues for trying to move this forward have been identified. Michelle kindly suggested this committee would like to. But also Jodie alluded to some functions that might ultimately be included in a CDC. There's a suggestion of a knowledge mission, a representative advisory board of experts to develop strategy, plan and prioritise, which I suppose aligns with the suggestion that you made. I think in the interests of time, it would be appropriate to just see if there are any additional comments about mechanisms or assistance that can be provided to the committee, and then we'll move to the last session of trying to summarise the issues that we've come up with today. Julie.
Julie Lees. I think it's useful, and this relates to other discussions as well, about looking at the broad spectrum of professions that are involved in this research and using language that says that we see your profession. So I'm obviously speaking as a former nurse and a midwife. Nurses have an important role to play in this care, as you've mentioned, Dennis. And allied health professionals, exercise physiologists, as we've heard. And so in terms of harmonisation, professional harmonisation as well is important to consider here and put into the language. Like, it's not just medical research, it's health and medical, and there are different professions that are relevant to that.
And I'm sure others around the table, like Anne and Andrew, would be very supportive. In fact, I think we're all supportive of that. Christine, you have your face showing. Did you wish to make a comment?
No, not at this point, but I wholly endorse that, and I just wanted to come back to some of the early wins. I really support a way to bring many professionals on board is to do things that everyone can access, and notwithstanding the comments on the proportion of people who are online, looking at the UK COVID support tool, it's translated into about 30 languages. And I'd just really like to emphasise for our multicultural country, we are very sporadic in the way that we have multi-language resources, and I'd like to emphasise that helps us be inclusive of all. Thank you.
Thanks, Christine. Are there any final comments that people wish to make, or questions from the Parliamentary Committee, or comments?
Well, perhaps if I can start. We are really interested in your ideas about how we can implement services for people who are crying out at the moment for support. And I think that's been pretty much predominantly what we've seen in our public meeting, is that patients are actually really struggling to get support. And we know that we have to do better data collection. We know that we have to really look at our research capabilities. But the predominant issue for us is getting support for our patients. And I can't emphasise that enough, that we don't really, I don't think, have time to do many more public meetings. We have to deliver a report to the Health Minister. He's very keen for us to have some ideas that he can act on fairly quickly. So if I can just make a plea for that. I'm very grateful for you all coming here today, and I know it's on Tanya's behalf, it's been very time-consuming for her to bring it all together, and I thank her for that. I thank you all for coming, but we are crying out for some help with what we can do quickly.
Yes, Andrew.
I think some of what we've been saying is we can act now to implement what's known internationally and study that carefully so that when we discover new things, we can change that implementation. But I suppose it's also important to say the health system generally is on its knees, and the levels of burnout and disengagement are at the places we've never seen before. So the reserve capacity isn't great. It's not like we really have, it's my experience at least, we don't really seem to me to have a lot of spare. And there are a lot of health professionals who are like, I'm sick of this pandemic thing, I just want to go back to what I used to do. Yeah. So I think we certainly can act now, and some of the suggestions to do what's known internationally. And I think we should do that and study that in an implementation way, so that when new knowledge comes through, say as told to us through a national evidence task force, that infrastructure is important, but implement now, I think, is a really good strategy. It's just a question of who was going to do it. And it's not just a question of education for health professionals. It needs to be a bit more than that.
Like a little bit more comment, and we might come back to a process by which that might happen. So first you, Alex, and then please identify yourself.
Alex Holmes. You can never underestimate how supportive it is to say, I hear you. So that, rather than I treat you, so saying I hear you, which isn't doing things, is a large part of this, I think. Yes.
Anne Holland. I think we have some examples of successful services for long COVID that you've heard about today in various health services. I think one of the reasons that health services are shutting those services is because they're nervous about demand. They don't think that they can cope with what's referred to as the tsunami of long COVID in the press. So I think what we've talked about in terms of having assurance of a tiered approach would provide a lot of reassurance to state health systems about the worth of those services and that there would be an underpinning in primary care. And we've talked today about, being able to make a diagnosis in primary care and people being confidently able to do that. Having self-management resources available that will help most people along with the messaging about recovery, and then a pathway into a specialist service if you need it. And I think if we know that only a small number of people are going to need that pathway because there's other things available, that will make it easier for state health to keep those open.
Lena and then Dennis.
Yeah, so Lena,
please identify yourself.
Lena Sanchi. I'd just like to add to that if we can, the way communities have currently tried to solve the problem when there isn't, is coming together in a community of practice. And these things are best done at the local level. And if you can actually encourage the states and the federal systems to come together, might be around the primary health networks, the state-based local public health units, and really at a micro level inspire conversations in the community amongst all the allied health providers and primary care and specialists to come together to solve the problem. You might get pockets like we've got here at the Royal Melbourne who are liaising with primary care and have their COVID clinics, and you might get cross-referrals. So I think coming together, inspiring that activity as a community of practice at a local level, and they can start that implementation model and get the message out and cross-refer to each other. That's sort of what happened during the COVID pandemic and how we all dealt with COVID on the ground because things were changing so quickly. So forming communities of practice that meet regularly, but you need those systems to come together.
Yes.
Yeah, Dennis Lau. I just want to point out on the supports that patients will require with chronic illness. I've been helping lots of patients to apply for example, NDIS support. And for example, long COVID or dysautonomia is not recognized as a chronic conditions that they will fund. So I think we need to also work along that end to provide financial and other assistance for patients.
Any other comments?
No.
Yes.
I just want to bring up the private sector.
Name, please.
Maria Crotty. So quite a lot of rehabilitation, outpatient rehabilitation, is done by private hospitals in sort of day settings, and not all of the funds are recognising long COVID as a reason for. So, and that is a sort of do tomorrow thing that could make quite a difference because it's not in the public sector, but it would carry some of the load.
Yeah, and I guess just Vernon, just adding to Lena's comment, I mean, you're talking about private sector providers recognising this condition. I think but linking up what are the top-down enablers for the development of those communities of practice comes back to Medicare benefit numbers and other things to actually make the driver for that to be sustainable in a business model.
Yes, Julie.
Julie Rees. I'm thinking about how you implement a vaccine program very quickly at scale like we did with COVID. And general practice is central to all of this. We've heard that, and maybe a very practical suggestion is to ask the colleges to prioritise CME-awarded educational sessions around long COVID with the limited but existing expertise there is, and include in that the Australian Primary Healthcare Nurses Association.
And just to add to that, it's Lena, the primary health networks get a lot of funding to provide education to the general practices in their catchment and the other primary care providers. So they're a vehicle. But also the state level public health units need to talk to the primary health networks too, so that they're coordinating their efforts.
So I need to sum up. Margaret, do you have a new comment?
Lena just said the primary health networks, that's federal, you get to control that, and you also get to control the Medicare benefit number for chronic disease and when it comes in.
Yes, I know.
So look, thank you very much to the roundtable attendees today and to the Parliamentary Committee. For us, I think it has been a productive discussion. I think we do need to work out just how to synthesise pathways forward. We've articulated a number, but to actually summarise them in the last 6 minutes is probably not a reasonable ask. However, if we look at it, we need an appropriate definition. The definition is really the basis of moving forward for research, for consumers, for communities of practice, for policymakers, for public health, and really for health planners, so that you can understand impacts on the workforce that are affected and impacts on society in general. I think we have identified a number of research options that need to support some rather more urgent suggestions for clinical care and the way that patients can be looked after and addressed in the short term, as opposed to acquiring more information, perhaps in the context of research being undertaken or information gathered as part of clinical care. We've heard about paediatrics and the special requirements there. We've heard about some of the vehicles that can be used to fund things, extending from Medicare for the clinical side of things, but seriously looking at implementation of research programs that are actually multidisciplinary or address more than just one discipline, trying to put forward for funding, and looking at ways of, although they're independent and have slightly different prospectuses, looking at the NHMRC and MRFF and ways that could be enjoined to actually put forward a research policy. There is a need, I think, for an advisory board of multidisciplinary or representative experts with different lenses to bring to developing a strategy or a plan. Now, I may have missed something, please tell me if I have, but that would be my conclusion. And really for you, Mike, is to tell us how best we can help support your deriving your messages and actions to take forward to the Committee of Inquiry.
Thank you very much, Professor Sorrell, and I have some concluding remarks. I'd first of all like to thank very much the Australian Academy of Science and the Australian Academy of Health and Medical Sciences for coming today. In particular, I'd like to thank Professor Tanya Sorrell for her hard work in bringing this together. It's quite remarkable that we've got the degree of expertise in the room today and, of course, online. And I can see Christine McCartney looking at me there, and great expertise online as well. So thank you all very, very much for coming. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Friday the 3rd of March 2023. You'll be sent a transcript of your evidence. We'll have an opportunity to request correction or transcription errors. I'd like to thank all the members and witnesses today for their time, and in particular our great expertise at the round table. I will declare this public hearing closed, but a couple of things I would like. First of all, Michelle would like this to be done again next week, so...
That's not nice.
It was really, really great. I think we learned a lot, and I speak, I think, for the whole committee in saying that. And the last thing, which Michelle did really say, we would love to get a photo of everyone together if you're happy for that to happen, and if you're happy to appear on social media.
Sure.